Good evening, everybody. On behalf of the Indonesian Society of Interventional Cardiology, I'd like to welcome all of you to join the Indonesian CTO meeting 2026 with Satoru Sumitsuji Sensei. It is a great honor for us to have Dr. Sumitsuji to join us in this session, because he is one of the, I think, leading CTO expert in Japan and I think in the world as well. So it is a good opportunity for all of us to learn from him on the CTO procedures. And I think Dr. Sumitsuji has written the very important manuscript in JAC, I think if I'm not mistaken, 2011. Yeah, I think about histopathologic insight and CTO wiring. I think this is one of very important manuscript in CTO procedures, and I think it must read journal for every interventional cardiologist who interested to do CTO procedures. And I think in tonight we will have the special opportunity from the first hand Dr. Sumitsuji himself to explain about the idea of this very important concept. I think again, thank you very much for everybody who come to this meeting, and then thank you so much also for all faculty who will contribute to this session, and as well for all sponsors to contributing to this event, so make this event successful, hopefully. And tomorrow we will have 2 cases for live demo, and during that live demo we'll have some lectures and also hopefully a fruitful discussion. Thank you so much for again for Dr. Sumitsuji, who make time to come here and to share your knowledge and expertise in CTO PCI. Thank you so much.
Okay, thank you. Hello, everybody. Good evening. And this is a very honor for me to be invited here and sharing my experience and the concept of how to do the CTO PCI. Actually, I started the CTO PCI almost in 1998 or something. So maybe 30 years already. And then so many the strategies coming. The integrated escalation, IVAS, CT, retrograde. And then the latest one is IVAS guided reentry. But anyway, so all of the strategy must be based on the CTO histology, pathology. Maybe you know if you know yourself and your enemy, you can get the success all of the fight. That is the old words from the Chinese tactician, the Sun Tzu. We know ourselves. That means the strategy, devices, something. We must know the enemy. Our enemy is a CTO itself. So what is a CTO? What is inside the CTO? Deeply understand. That is a very good chance to success the CTO PCI. Okay, starting. This is already the doctor informed the 2000. Oh, this is okay. 2011. My article on the JAC intervention. This is very important figure. How to generate the CTO. Most of that, of course, nobody knows in detail. we cannot see inside the patient coronary, just the beginning, the starting the CTO making and completely grows up. But anyway, this is a widely believed scenario. First, occlusion, plaque rupture something. And then thrombus formation coming up and then down. And then stop with a side branch flow. If the good side branch flow there, thrombus formation stop it. And then finally making the fibrous cap. And the fibrous cap, proximal and distal is quite different. Because how to make the fibrous cap? That is attacking with the coronary flow pressure. Antegrade coronary flow, retrograde coronary flow, the power is quite different. Retrograde is just on the collateral flow, very weak. So in the pathologic, some of the CTO doesn't have the fibrous cap in the distal. All of the CTO have the proximal fibrous cap, but the distal fibrous cap is totally different. That's very important for the retrograde wiring. Why the retrograde wiring? Always not needed stiff wire. Intermediate wire can go up, especially inside the plaque. Why? Because fibrous cap is very weak. That is a very big important point of the retrograde benefit, advantage of the retrograde wiring. But anyway, proximal is sometimes very tough. Then, next step, loose tissue. Loose tissue is a kind of the part inside the CTO. Pathologically, CTO segment is not totally occluded. There's many studies show it. Sorry. Of course, angiographic totally occluded. Angiographic totally occluded means the contrast never go in. However, space still remain. In some CTO, especially younger CTO, subacute, and then the 6 months CTO, that is a more frequently having the loose tissue inside. And then 3 years, 5 years, 10 years. Year by year, this occluded part change to the organized thrombus, and then more stiff. Sometimes this is a calcium. This kind of the changing is happening in the CTO region. So, loose tissue, like this one, that is a very good for the wiring. And if our wire pushing force, okay, driving force of the tip of the CTO wire, beyond the resistance of the loose tissue, if the force is stronger than the resistance, okay, go in. And think about the resistance in the vessel wall. Vessel wall is a much stiffer, harder than the loose tissue part inside the CTO. This is the original plaque. If we can control the pushing force, driving force of the tip of the wire between resistance of the loose tissue and the resistance of the vessel wall, original plaque, the wire automatically traces the loose tissue only. This is you can imagine AMI wiring, acute myocardial infarction. Everybody can pass through the wire. Why? Because the fresh thrombus, that is very weak. Resistance difference between the fresh thrombus and the vessel wall is very big. So we can easily control pushing force between the bigger than the fresh thrombus, but never migrate into the vessel wall. The kind of the procedure, very easily we can do it. That is why AMI wire pass through, even using the Lancer, Sion blue something. Concept is the same. So all of the CTO still remain as loose tissue or not. Nobody knows. Unfortunately, even doing the CT, even doing sometimes the entry IVUS can show some loose tissue image, but most of the case, we never know. We cannot get the information of the loose tissue exists remaining inside the CTO. How to know that is a wiring? So, first wire should not use a Conquest Pro, should not use a Gaia Next 3, Gaia 2, 3 from the beginning. Why no? Because sometimes loose tissue remaining, but stiff wire easily migrate into the vessel wall, original plaque, and then finally go to the subintimal space, extra plaque space. That's a very difficult situation to get an integrated, simple integrated wiring. Okay, so when using the intermediate wire, for me, Sion black, sometimes Neos 3, sometimes whatever, I don't have the other option, but something intermediate wire, XDR something. At the time, what is the thinking point? Cross the region? No. Check. Explore. Checking the loose tissue remaining or not. If intermediate wire easily go down, that is a proof of remaining the loose tissue. Only, oh, God bless us today. Something like that. Very lucky, loose tissue connected the proximal to lumen to distal to lumen. Wire automatically pass through, like the AMI. Of course, longer CTO. Even some part is remain the loose tissue, but on the way, there is no loose tissue, intermediate wire stuck. Then think, oh, this is no chance of the loose tissue tracking from the start over end. Then try to advance a microcaster or something, and then change the stiff wire. And then stiff wire wiring should be started. So never start with the stiff wire. Reason is try to search, try to check remaining loose tissue. This is, you know chikuwa? Chikuwa, Japanese food. No, chikuwa is like the fish meat. And then not so very hard. Not like the stone, but not so very soft. And then you need a jelly something. Jelly is very, very soft one. Pack into the chikuwa. This is loose tissue and then vessel or something. Think about stiff wire or tapered stiff wire like the Gaia something. Wire very easily going out from the jelly part and then come into the chikuwa part. That is wire migrate into the plaque. So first step must be more softer wire. Of course, CT also not the soft wire, but the intermediate wire. And then sometimes XTR, the kind of tapered wire, easily go into the plaque. So taper entry CTO, I still using the XTR, XTA, but non-tapered the CTO, I already stopped to use the kind of the wires because 0010 wire is very easy to bending, softer, so very difficult to control the pushing force. Tapered entry, that is okay, no space there. So XT series is a nicely work, but blunt or abrupt at the time stick, the XT wire easily bend. Very difficult to manage, control. So I like to use a 14,000 wire, like the Sion Black or Neo 3 or something. And then next one. Next one is a subintima, extra plaque. Of course, you already know subintima tracking. Extra plaque tracking is a sign of failure, way to failure with the wiring. Why our wire going to the subintima? Can we avoid it? This is a pathology image of the CTO, okay? Proximal fibrous cap and the side branch, and then of course still remains the root tissue there, but the point is not that point. Think about the size of the wire tip. 14,000 wire or XTR 10,000 wire, Conquest 9,000 wire. What a size inside the coronary? You know 14,000 in the millimeter. This is a millimeter, 1 millimeter. So this is an entry point like the 4 millimeter in the vessel size and the plug 3.5 something. 14,000. How big it is? 14,000 actually 0.35 millimeter. 0.35 is a relatively big size compared to coronary artery. And subintima, where the subintima it is? Subintima is space between media and adventitia. Okay, so if the wire not cross media, that's a good wiring. We have the chance to simple wire the success to the distal. But the media, how thickness of the media, you know it? Media is always less than 0.5 millimeter, 0.3, 0.2. Remember, 14,000 wire tip, that is a 0.35 millimeter. And media is muscle, smooth muscle cell. Wire tip is a metal, which is stronger. Of course, wire is much, much stronger than the media. So once the wire go to the media direction, media cannot stop. Easily pass through the media and then go into the media adventitia space. Luckily, adventitia is like the rubber. Adventitia can be expand 1.8 times. This is 1.8 times. This is not a human coronary artery, but a pig artery. Pig artery is very similar with the human. And then this is a very nice data. How big, how much can be expand the adventitia. Almost 148 millimeter Hg is a normal, the systolic pressure, right? Normal systolic pressure attacking to the adventitia itself, not without the media, without the plug, just only the simple, pure adventitia. Pure adventitia expand 1.8 times. That means a 4 millimeter the vessel can be 7.2. Very big. But remember, guiding catheter dissection, like coronary something. After the dissection, vessel become very big. So 1.8 is my data. My data is the biggest hematoma. That means a completely collapsed two lumen. That's the situation of the probably fully expanded adventitia. That is around the 1.8. So 1.8, I believe it. And then 1.8 expand adventitia. How about the media? Media is a smooth muscle cell. Media is not the expand, like the more, what should I say? Yes, sure. Media, that is a control the blood flow volume. Normally, make smaller, and then the blood flow that decreasing because no need the demand is there, and then more exercise sometimes, stretch, and then more flow. The kind of the purpose, the mechanics is media's mechanics. So media is not expand 1.8 times. Adventitia can expand. That means we can have space between media and adventitia. And this big space, so-called subintima, can be very big. Now, another name is the extra Planck space. And then finally, like the guiding catheter dissection, pressure, blood flow coming into the subintima space, extra Planck space, and the pressure over the subintima beyond the two lumen, and then vessel wall. That makes a collapse the two lumen. That is the happening of this two lumen is disappear after making the subintima tracking. And then this is the most of the mechanism of the failure of the antiquated wiring, simple antiquated wiring. And also, after making a big subintima space, wire control is very difficult. How we can control the wire tip direction? That is, fix the wire body. Wire shaft fix, okay, we can rotate the wire tip. And then clockwise, counterclockwise, go right side, left side, up or down, something. But after wire shaft come into the big space of the subintima, shaft moving, we cannot control the wire. Many times happen, okay, go to left side, looks like they go to the lumen side, and then clockwise, counterclockwise, left side, and then go down. But again, that is not go to the correct way. Why? That is a shaft moving. Already shaft move, and then just go around the target. This is a mechanism of the failure pattern of the simple antiquated wiring. Okay, so important point is not to advance the wire into subintima space. However, this is difficult. Short and straight and non-calcium CTO. Okay, we can control the wire nicely. Now we have the nice wire, Gaia, Conquest, something. So we can control. Under control, keep the wire shaft inside the plug, and then 3D wiring, and then get success. However, long run, having the tortuosity, bending, and then many times the calcium there. So wire kick out from the center of the vessel. Off from the center of the vessel, that means go to the media side. Media cannot stop the wire tip. Beyond the media, go to subintima. So, most of the CTO, not the most. For me, my target CTO is a very tough CTO, literally or local doctor give up CTO. So for me, simple wiring, keep the wire tip inside the plug is quite difficult. Of course, your CTO is much more. The shorter one, younger one is remained included. So you should try wire inside the plug and then control and then try to get the disattunement. However, not always successful because calcium there. Even straight, but calcium here. Calcium wire not stronger than the calcium. Calcium is a bone, cannot pass through, slip. Then go to the side of the vessel and go to subintima. So please remember, wire unavoidable subintima wiring. Wire always like to go to the subintima direction. Sometimes skill set can avoid, but not perfect. So after go to the subintima, another very important point is wire is already subintima or not. Judgment. I didn't put inside this presentation, but maybe Sunday I will talk to you. But simply said, the sigmoid curve. Because like this is a vessel, and then wire go outside, that is with a NGO, fluoro, that is a sigmoid curve, S. Or big knuckle. Inside the plug, wire never makes a big knuckle. Small knuckle, okay, but a big knuckle, like the 4 mm, 3.5 something. same size of the vessel diameter. That is sign of subintima. Then after the wire go to subintima, how to do it? Try to advance more. No. That is very, very low success rate. For me, less than 1 in the 20, that means 5%. That is a lucky success rate. So, subintima wiring, keep doing the subintima wiring is a no way, no value. After understanding, this is a go to subintima, stop this wiring, and then go back to the interplug wiring. How to do it? Sometimes we can do with not here, correct. We can do parallel wiring. Many doctor. Okay, this wire looks good to subintima. Next step is the next option is the parallel wire. But think about second wire already start inside the subintima. That is almost no meaning, no value, because this is also 5% success rate. If we have something, the information, just the expectation, that is okay. Maybe this curvature wire go to the subintima, so we control this side. Can keep doing the interplug wiring. If you have the kind of the something, the thought or something, the idea, okay, you can go to the parallel wire. Or very close first wire. Looks not subintima, but inside the distal lumen. Sometimes happen is that this is an intra-plug force lumen. So at the time, parallel wire is a very nice option because we can start the wiring from the inside the plug. So think about the parallel wire. Okay, can we advance the second wire going to the interplug or not? If you don't have the any confidence or sign or something doing the interplug tracking, no need the parallel wire. Go to the stingray or IVAS guided reentry or retrograde. The updated strategy is based on the subintima wiring. So even the wire going to subintima, now we can get the success. But it needs another special skill set. And the other point is how to do the interplug wire tracking. For me, think about of course I already talked to you, loose tissue track. This is always first step for me. And then after failure, intentional interplug tracking. That is using the stiffer wire and the 3D wiring. And then sometimes, if there is a still chance, we have chance of the interplug tracking with the second wire, okay, parallel wire. This is my steps. And then intentional plug wiring, is nearly equal to 3D wiring. Now, I have the nice steps. Anatomy-based 3D wiring. That was made with younger doctors. My colleague, younger doctor, still cannot understand 3D wiring. I say, clockwise. But he said, clockwise? Sometimes I asked him, is it the situation you do the clockwise or counterclockwise? He said clockwise. No, that is a counter. Many times happen. Why so different? Understanding is incomplete. So I discussed with the younger doctors and made it this one. Maybe you know Okamura Sensei's way, near or far, something. Many doctors say, I got. But honestly, he didn't. So this is another. Maybe this is good for you. I hope it. So one anatomy basis. So LAD and the right coronary circumflex are different. LAD, okay, kind of the caudal view, areocaudal, epicaudal. You know, this is a pericardium side, okay? Agree? This is the myocardium side. Agree? Okay? And then this is LAD, focusing LAD, not a circ. LAD, and then this is cranial view, epicranial, areocranial. This is septal side. Agree? This is diagonal. You can do the 3D wiring. So, go back to the cross-section. This is imagination. Like IVAS. You do IVAS? Okay? IVAS looking from the proximal to distal. So, think about this is the LAD, top side of the pericardium. We are going to the LAD. Pericardium, myocardium, septal, diagonal. Okay? Okay? Okay. Good. And the next one. Shaft and the tip. One side showing shaft and tip, the other side, not complete 90 degree, but almost 90 degree, around the 90 degree, that's become the straight, okay? Because a single bend on the tip of the wire. So this is so-called myoperi, because the shaft is myocardium, okay? Tip is a pericardium. This is a relative direction. So maybe some of the doctors think this is a pericardium. No. Compared to shaft and the tip. So shaft relatively myocardium. Tip relatively pericardium. Agree? Agree? You can say perimyo. Myoperi, myoperi. And this one, also myoperi. Shaft, tip, both located inside the myocardium side, but compare which is more myocardium, which is more pericardium. So shaft myocardium, tip pericardium. Okay? Myoperi. This one myoperi, this one myoperi, this one myoperi. Okay? And this one, this is septal side. So this is a myoperi, and then wire itself is the septal side. Go next. Myoperi. Like this, shaft and tip. Okay? And the septal side. So which rotation the wire tip go to the center of the vessel? Clockwise? Counterclockwise? Counterclockwise. Everybody agree? So maybe this one come to here, and then sorry. Like this. We focus in the curvature of the tip. Sometimes this can be like ちょっと待ってよ。No. Oh, cannot move it. It's okay. Sometimes not a completely straight. Some bending. Okay? But which is more bended image? Caudal or cranial? And then this one, cranial is more bended. And this is a sep D. Shaft septal, chip diagonal. Okay? Again, this is also sep D. This is also sep D. Never confuse. The position is this is both diagonal. No. Either one. Sep to D or D to sep. This is a sep to D. Sep D pericardium. Okay? Agree? Sep D pericardium. Sep D. So like this. Sep D. Okay? And the pericardium. So here. Counterclockwise. Easy. Okay. Never mistake With this method, my younger colleague, 100% the correct answer. Before this method, 50-50 something. 50-50, just lucky. Next, circumflex. Circumflex, there's a no septal and a diagonal. Also, perimyo is same. Pericardium, myocardium. And then atrium ventricular. Right? This is very similar to the right coronary. Right coronary also, pericardium, myocardium, ventricular, atrium. Okay? Difference between the circ and the light is direction of ventricular atrium is the opposite. Because the right coronary go this way, circ this way. So pericardium, myocardium, ventricular atrium. So right coronary, if we can go into right coronary, pericardium, myocardium, ventricular atrium. Go to the circ. Go to the circ, pericardium, myocardium, ventricular atrium. Ventricular atrium position is the opposite. Just only that point. And, for example, circ like this. This is a perimyo. Shaft, pericardium. Tip, go to the myocardium. And then ventricular. Perimyo ventricular, perimyo V. Perimyo V. So this is clockwise. Perimyo ventricular, so clockwise. The tip go to the center of the vessel. So this is I think this is a kind of the riding the bicycle. Before getting the skill set of the riding bicycle, looks very, very, very difficult. The once after getting the skill set, very natural. No problem. Something like that. So please keep training. And then not only the CTO, but the normal open vessel. Oh, this is a perimyo, and then and the other side, check ventricular. Also, counterclockwise go this way, clockwise go this way. And then once the rotate wire and check the other side. Oh, my tip is go to my expected. So you can do the 3D wiring. No more difficult point. No. 3D wiring is not perfect because 3D wiring from the subintima space doesn't work because direction correct, but wire shaft moving. So after subintima wiring, 3D wiring method is not good work. This is one of the, for me, one sign. I do almost all the 3D wiring is very natural. I can understand the very quick. Oh, this is clockwise. And the clockwise, but wire tip not going to the right spot. I think maybe already wire is in the subintima. Another point is calcium. Even the direction, rotation direction is correct, but if there is a calcium, wire doesn't move. So not complete, not perfect, but very important. And the interplug, that is very nice. And another way is based on the histology. Plug to sub is easy, but the sub to plug or sub to lumen is very difficult. This is very important concept, and that is very important for the retrograde. Retrograde, 2 wires coming. Plug, sub, plug, sub. And then this situation is changed with a longitudinal. In the proximal part, anterior wire tend to be inside the plug. And then anterior wire go to subintima. Retrograde wire, this part still keep inside the plug. But after going up, go to subintima. So retrograde, 2 wires overlapping, and then ballooning, simple the reverse cut. Of course, we can try. But after fail of the simple, the reverse cut, do IVAS. Sorry. And then understanding the situation. ありがとうございます。Then, ありがとう。テレマカシ。And then, we can decide which strategy we can do it. Puncture or ballooning, something like that. Okay. So this is quite the brief summary. My current strategy, almost all cases, starting with antegrade. And loose tissue tracking. I always respect the loose tissue. I like loose tissue. I like loose tissue tracking because that is a safe, not using stiffer wire. So that means the less risk of the wire perforation. And then quickly go down. Sometimes pass through. Oh, that is very good day today. So loose tissue first. If loose tissue cannot, go to the intentional 3D wiring. And then if the wire go to the subintimal, go to the IVAS guidance or retrograde. That depends on the channel situation. Now, of course, the proximal to room situation is a very, very difficult, very risky antegrade wiring. At the time, primary retrograde is one option. And also CT and IVAS. Maybe CT is not so popular in Indonesia. And then also how to use a CT image. Someday I will show you this one in detail. This is a DICOM viewer. Actually, I asked the AI cloud code, and then I made it this one. And then this software application, we can see, we can assess the CT image by ourselves. And a very important point, this is a free software. No need to pay. Because a free component. So I cannot get the money from this application. And then this application is open in the GitHub. Yes. Maybe some of the doctor cannot join the Sunday. This one. This URL, and then you can connect to the GitHub, the website, and then release latest version. You can download free. This is the image. GitHub. This one. Both of the Mac OS and the Windows available. So you can click here and then download, and you can use it. Okay, this is not a short, but a short lecture for the histology-based CT PCS strategy. Thank you for your attention.
Thank you so much, Dr. Sumitsuji, for your excellent lecture. Any questions from the audience or panels? Yeah, Dr. Munawara.
Sumitsuji Sensei, thank you very much. It's very nice talk.
Please, panelists, please sit here. Yeah, silakan. Yeah. Yeah, it's okay.
You said that the proximal cap is quite hard. And then there are two possibilities, of course, that we have to do for CTO procedures. One is that to puncture might be IFS guided, or might be we have to do with the retrograde. Which of which? I mean, that's when we prefer to do puncturing, IFS guided, or we have to do with the retrograde.
Yeah, very good question. Up to that is very much depends on the operator's skill set. For me, up to the conquest, the 12, I can try the puncture without the retrograde preparation. But more stiffer, sometimes I use a Conquest Pro 12 ST or 820 is needed for the anterior puncture, fibrous cap puncture. At the time, very, very high risk of the perforation. So my strategy is retrograde first, and then, of course, the retrograde passing through the interplaque and the retrograde wire cross is very, very lucky. But even the retrograde wire going to subintima, but create subintima space. Like, show me my presentation again, please. That means how the wire can perforate the vessel wall. Situation of like this: media adventitia fix. Imagination the two papers fix, and then punk with a pen or something. We can punk out both of the paper, but make the space here, and then punk. Not easy, both of them. Inner one, easy to punk, but there is space. So the puncture needle or something can stop the inside the space. So I intentionally make the subintima space. And then punk stiff wire 820 or the ST wire into the space. So my answer is, for me, up to the Conquest Pro 12, normal 12, I small try. But if failure, I feel the dangerous feeling of the wire perforation, okay, try to go to the retrograde and then make the subintima space and then punk subintima. This is my answer.
Well, it's say maybe for Sumitsuji Sensei, maybe it's easy for us, maybe not, because
yeah, that is of course based on experience and the skill set.
And then the other thing that it's 3D wiring.
3D wiring, yeah.
It's look like for me it's very difficult to understand, because you know.
It's much more simpler.
That should be practicing and practicing again and again. I mean, that's if we are still, that's when we start to clockwise and the clockwise. I said that maybe around 1 centimeter, 2 centimeters.
Again,
some experts say that maybe after, couple of centimeters, 2 centimeters. When we are starting to do
3D wiring.
Yeah, 3D wiring.
I always, from the beginning, think about it. And then I skipped my slides, but the wire movement, rotation, what happens inside the CTO, that is a blunt dissection and make the space here. So why the CTO wire move forward? Not continuous advancement. There is some advancement, and it looks, good way, good direction, and again, again advance. this kind of jumping in continuous the advancement. Why? That is rotation make the space. Rotation make the space, this is the make the dissect. And dissect is not the hold the round shape like the sinner. Then wire tip direction, just much for this direction, wire move. Probably this is correct, the understanding of the wire advancement inside the CTO segment. Then, important point is this dissection space direction. If this direction go to the sideway, go to the peripheral side of the vessel wall, it tend to go to the subintimal space. So I always wire tip go to the center, center, center. So I do.
So you mean that we have to see from the orthogonal view?
Yes, there is one view that we can see like this, and the other view needed.
Oh, right.
So proximal LED, areocranial is my working view, but sometimes areocranial and areocaudal. We have to know the peri or mio. Peri, mio, and the sep D. These two information, after getting to information, I can do 3D wiring. So I move CM a lot, or by biplane angiogram. But the biplane, the limitation is almost no angio machine can make the areocranial and the areocaudal. So just areocranial and areocaudal, areocranial and the left lateral, something way. Anyway, we must even the move, and then check the information via tip position direction.
So what the best wire that you have to do with the 3D wiring?
Yes.
What kind of
wire?
Yeah.
More than kind of gradius. Intermediate wire is not so good for the 3D wiring because the intermediate wire is focusing the root tissue tracking. Not so controllable. But for my wire selection is Sion Black, Gradius, Conquest Pro 12. So after the Conquest Pro 12, always think about the 3D wiring. And the Gradius also not so easily controlled, but think about the 3D. Sion Black, almost not thinking the 3D, just track the root tissue.
Yeah, that's the wire that's not available in Indonesia, which is, that's the Conquest what?
Conquest, Confianza. Conquest.
No. That's for 3D wiring, which is not available in Jakarta, I think.
ST?
Yeah.
ST.
ST, yeah.
ST also need the 3D wiring.
And one more question for me. You say that you start with the intimate tracking first. Intimate tracking first, meaning that you need taper wire like XTA or something like that.
Sion Black.
Sion Black, yeah. Then when you said that if you fail, that you move with it directly to the 3D wiring, or you have to,
the Sion Black stack.
Yeah.
Go to the Gradius.
Oh, okay.
Now Gradius EX.
All right.
That is a kind of the personal favorite wire series is there. So for me, polymer jacket is very, very much fit for me. And then polymer jacket wire, again, please. Retrograde or the dissection re-entry or IVAS re-entry procedure need a subintimal tracking. And the subintimal tracking is a very dangerous situation for the wire perforation because no media there, no plug there, just adventity outside. So how to do the safe subintimal wiring? For me, not the push just more rotate. And then blunt dissection. Push and punk. That makes the punk out, the adventitia. So intima plaque, you know the left-hander and the right-hander. Contour the wire, there are many Japanese doctors, the left side, this one. Go and back left hand, and then rotate right hand. But all the textbook showing this one. But my style is different. My style is all of the procedure doing the right hand. Push and back and rotate. Because I'm right-hander. This is a joke. anyway, left hand is not so good feeling for me. And just only that, even in the CTO segment. And then this style, rotate with small pushing. So wire move like this, more dissect wire behavior, not the punk. This is a kind of a puncture, just a push. Push without rotate. This is a left hand feature. Me, both. Pushing, but more rotate, more dissect. And this is, I think, much better for the subintima tracking. As I said, puncture is dangerous for the inside the subintima. So some doctor, Japanese doctor, the master level doctor talked to me, Gradius is a perforatable wire inside the subintima. But I use a Gradius much more than him, and then I almost never perforate. Probably based on how to control the wire. He doing punk. I never punk it, especially inside the subintima space. More rotate.
One more, Sensei.
Hi.
If we have a subintimal space, for example, say we cannot go there, then you said that we can do with re-entry, but IFS guided. Is there some trick and tips for that?
Okay, the one is good wire, ST. ST is a conquest shaft with a Gaia next to tip. So show me again, please. Probably I have the photo of the tip. Yes, this one. There's no ST, but the ST tip is like this one, very sharp. And then this is a Conquest Pro. Conquest Pro tip is very round. My size is 0.09 or 0.08, but it's still round. But Conquest ST, 12ST is a Conquest shaft with Gaia tip. So more puncture. So the IVAS guided re-entry need a puncture force.
In other words, that's in the space, in the extra plug space, you put the two wiring.
Yes, two wires.
One for IVAS and
yes,
one for
yes.
All right.
So IVAS and the microcaster.
Right.
And then the small tip, but the important tip is not the vacuum, the air bubble.
Oh,
After air bubble come into subintimal space, IVAS cannot see it.
Oh, okay.
So very carefully, the advanced wire using the double lumen caster, right? And then drip the water, saline, not to vacuum the air bubble. And then carefully change IVAS and then microcaster.
Any question from the floor? Yeah.
Thank you. Very nice lecture. I would like to ask two questions. So the first one, if your wire goes to the subintima, and that's, as you said, there's going to be have a intramural hematoma. So how to avoid such an intramural hematoma?
Hematoma. Hematoma unavoidable.
Yes, but how to avoid
Minimize?
minimize. Whether
So-
using a guide extension for that or
So blocking the antegrade flow.
yes.
That is
How you block the antegrade
of course, that is good idea. And we tried. I tried, for example, I tried to use a balloon tip guiding catheter. That is not for the coronary. That is for the brain. That kind of guiding catheter there. So I tried to use it, but that failed. Because that is straight, cannot go in. Anyway, so using the guide extension catheter, using the balloon trapping, not the trap, but the balloon blocking, but not so effective because the antegrade flow is very powerful. So sometimes the balloon deflate already go in. And then if the hematoma resistance, so that means the resistance of the vessel wall, the dissection resistance is lower, very smoothly go down. So very difficult to control.
I see. So the second one is if you encounter the blunt stump.
Blunt stump.
So no side branch.
No side branch.
So
Tough.
how you puncture it?
Pray. Well, of course, the first most important point is try to find the sticking point. Without a stick, just a sleep. Why never going?
How you know precisely that it is already in the intraplug?
Just one is resistance. So in the coronary, most lowest resistance, the segment part, is a true lumen and then extravascular. Extravascular just only the fat. Lumen is lumen. So if we don't have the resistance to advance the wire around the entry of the CTO, the most of the case already perforated. So keep checking the resistance.
Okay, the last one.
Right. But that is very difficult. So try to find out a sticking point, and then, of course, at the time already start the 3D wiring. So for example, the LED CTO, not a no side branch. We have the SAC or something. However, very difficult to punch in. At the time, try to find out the sticking point, and then just some advancement, stop the wire, and then check the spider, caudal, and the cranial. And then think about this. Most of the time, go to the myocardium side. I try to go advance the carina side, that is the myocardium side. And then this is a D-SEP or SEP-D. SEP-D clockwise, D-SEP counterclockwise. If we misunderstand and miss the procedure, we can do it, the wire easily go outside. So even from the beginning, more step-by-step 3D wiring, I always doing.
Okay, what's your opinion regarding TD-ADR? TD-ADR, and then the second one is HDR. HDR.
XDR?
HDR, yeah.
XDR wire?
No, hemodynamic.
HDR.
Hydrodynamic, yeah. Yeah, hydrodynamic. What you call?
HDR, I think that is one option. The contrast, that is the most soft guide wire. Like. So HDR, for me, I think no need for me because I can pass the kind of the lesion. HDR, the something, the connection looks confirmed by the dye injection. That means the root tissue there. Even without the HDR, my wire can trace the root tissue because of my experience and my skill set. So for me, almost no need a HDR. But a younger doctor, or even for me, very difficult situation. Now after retrograde, but the wire not go in. At the time, I did several cases try to do the HDR. The one thing, don't misunderstand 0.5 milliliter. 0.5 milliliter contrast injection. That is a HDR article showing. Did you calculate 0.5 milliliter, how much it is? That is a 3 millimeter balloon, 3 by 50. That is 0.5. 3.540, that is 0.5 milliliter. Do you want the kind of big amount want to inject inside the coronary artery? So actually 0.5 is not correct, 0.1 something.
Okay.
And then most of the time, I check the Fujita sensei's procedure or something, and then much the contrast come back to the proximal, to lumen. So actual volume inject inside the total occlusion is much less than 0.5.
So
and must be much lesser.
Insulin syringe.
Syringe is small syringe. But anyway, no, one thing I want to share with you is 0.5 is too much. And then the other one is TD-ADR.
Yeah.
Of course, the TD-ADR is very nice. I love it. And then the key to success is the one I already talked to the Dr. Munawa, the Conquest Pro 12ST, stiff wire. Of course, sometimes we can get success, Conquest Pro. Actually, 10 years ago, 15 years ago, I was the basically I was guy. So I did a TD-ADR so many times from the many years ago. However, success rate is not so high, 30% something, less than 50, because the wire just only the Conquest Pro with something round shape. So ST is very important, that device. And then one more very important point. That was I learned from the Dr. Okamura and Dr. Yoshikawa. Close puncture point must be close to the target, the wire shaft close to the target. I tried like this one, big curve, and then far away, and then try to puncture it. But that is easy to make the bending. So not successful. Very close, so checking the IVAS very carefully. Then not only the size of the hematoma big size, however, wire shaft very close to the target. That is a chance. And then fixation of the shaft. Shaft move, like the subintimal wiring, same. Shaft move, very difficult to punk. The shaft fixed by plug or by IVAS catheter, that is a very good situation to punk it. So selection of the puncture point, that is the key to success.
Okay, thank you very much.
Hi.
I think its DR should be intra-plug, isn't it?
No, I'm talking about from the subintima.
Oh yeah.
And interplug, of course, the Okamura sensei, Yoshikawa sensei procedure, 2/3 is a interplug procedure. Tip detection, ADR, I don't think that is not using the ADR, but tip detection and wire re-enter into the plug. That is a good idea, and then actually that is more frequently done. So intra-plug rewiring, reroute, and then get the success. That is also important point of the TD-ADR. TD.
Thank you, Dr. Sumitsuji. I think or I realized that CTO cases, especially the real CTO, is the most difficult case for training. Because what defines how is the characteristic of the tissue plug is not very easy to translate into narrative story until we find or we touch that case. Do you think until now, is there some sort of simulators or animals cases that we can use as a training program for real CTO.
Yeah, that is very difficult.
Yeah. Or is there any idea that some robotic system can help us? Because
one thing, you know the Messi, Cristiano Ronaldo.
Oh, Ronaldo, yeah.
Nobody can make it.
Yes.
So that kind of a high-end CTO operator cannot be trained by the education system.
Yeah.
That is a kind of the genius or kind of the something crazy talent is needed. But anyway, the average, that must be trained by the, I think, model, simulation model.
But I think for the device like wire you mentioned from XT, Xeon Black, I think it's the result of the experience of the cases.
Of course, but my experience, not so easy, but we are now making the simulation training model for the CTO.
Oh.
Retrograde step, we already made it.
For the retrograde.
Retrograde steps, how to select the channel and how to negotiate the channel and how to do the reverse cut, simple reverse cut.
It's much easier to explain.
More difficult point is wiring.
Yeah.
Because we cannot make the CTO model.
Yeah.
That is very difficult.
Thank you, Dr.
Sumitsuji. Now back to this, the retrograde technique that contemporary retrograde technique now. Do we still using surfing or we have to injection?
I do injection. I do injection. Right. I want to advance wire after getting the root, clear root, kind of the map. So surfing, I did surfing a couple of times after failure of the normal step.
And then
only for the septal channel I try to do it. But mostly I do tip injection, very carefully tip injection to make clear the root. Okay, this is going to go to right side, left side, and then down, something like that. And then advance.
And then the wire itself, and then let's say it's Xeon Black or might be when we are using Xeon Black or when it's Xeon 3 and then or might be XTR or whatsoever. I mean, is any trick and tips there?
That my personal way, it is almost never using a Xeon Black for the channel.
Never.
No, never.
Because some experts use
I know. But they make the perforation so many times. And then surfing, very good point of surfing is never do the injection. So never know perforate or not. And I don't know how much the trouble, but I think that some of the kids have the trouble with the wire perforation without the checking. So I do checking, so big perforation, I do the coiling to save the patient not to make the problem bigger. And anyway, so I using the Xeon and then Sozos mainly, and then Xeon, and then XDR for the septal channel. Those three is my selection of the wire.
So when Xeon
is the septal.
SO3
is very soft. And the SO3 cannot pass through. Sometimes the septal is a septal squeeze, myocardium there. So systolic situation, that is a very much resistance to go down. Other times, sometimes Xeon is much better than the SO03. Right. So starting with the SO03, and the SO03 stuck it, and then looks relatively straight. Okay, that try to Xeon or try to the XDR.
All right.
Okay, any other questions? Dr. Sumitsuji, I think you told us that to do the loose tissue tracking using the intermediate wire. In the certain stage of the CTO, we found maybe around 20 or 30% of microchannels. How about the concept of microchannels wire using a kind of like a XTR or XTA or something?
Microchannel, historically, there is a size with the 0.1 millimeter something. Okay, and then the 0.08, even the 0.08, there is a 0.2 millimeter in the diameter. So just tracing microchannel is almost impossible. And then microchannel always not straightly connect to the proximal to distal. There is a stop in the way or a turn back or something. That's why contrast not going. So in that situation, I don't have the idea of the microchannel tracking. Microchannel is a part of the loose tissue. So 14,000 wire or 10 wire, and the kind of the breaking the loose tissue and they go down, and then in the loose tissue, microchannels remain included.
Okay, I have, since the microchannel is usually less than 0.1, right? Like XT series is 0.09 and 0.1.
So 0.2 or 0.23 something.
Yeah, I think, So in that situation, sometimes we can reach further with the XC series because of maybe the size is a little bit smaller than the microchannels. I think so. What do you think about that?
So XC something they're using for the microchannel tracking.
Yes,
asking to me.
Yeah, because I think it's safer because you know these softer tips rather than intermediate, right? What do you think?
Yeah, because the tip load is a little bit lower, but the tip area is smaller. So divided by tip load by the tip area, almost similar. So penetration power is not so different. And as I talked to you, the blunt type entry or abrupt type entry remaining the certain size of the proximal to lumen, that means the space, using the XT wire, the thin wire, is very difficult to control, the easy to bend, because very difficult. So at the time, I like to use a 14,000 Sion black or something. And then tapered entry, that's okay, there's no space to make the bending. Okay, XTR, XTA, that's a good selection.
Okay, thank you very much. Any other questions? Yeah, maybe participants? Ya, silahkan Dr. Manggiring.
Thank you, Sensei. I'm Manggiring. I have a simple question and practice simple. How do you tell to us that the sensation of when we push the wire, now you are in the soft plaque or fibrous, or you are touching the calcification, and the sensation in our finger like that. And then when you fail to cross the wire, and then we pull back the wire, now it's difficult. So what does mean? Our wire now in fibrous or calcified or soft?
Okay.
And then the second question is, how is the better combination to push the wire and rotate the wire? It's one hand or two hand? Thank you.
First question, very big resistance when the pulling back. I think we have the types. One is, and the more frequently is a subintima. Subintima space, I don't know why, but the subintima space strongly catch the wire tip. So like, boom, this kind of feeling. Most of the case, more than the most, almost all case is a subintima tracking. And the possibility is a calcium. Inside the calcium, at the time, similar feeling and very difficult to pull back. But the calcium is calcium. We can know by the angiogram or by the CT. So without calcium and this kind of a feeling, that is a subintima. This is my understanding it is subintimal resistance. Number 2 question, right hand pushing and rotate or separated push and rotate. Which do you like, the Japanese food or Chinese food or Italian food? That is a kind of preference, I think. And then also the education. My teacher is a Kato sensei, Osamu Kato. He's the right hand controller. No, he said himself, he said, I use the left hand, but I carefully checking, he almost using right hand. So I learned from the Kato sensei style. I use almost all the right hand. And then one time, maybe 35 years old sometime, you still remember Tamai sensei? Dr. Tamai, Professor Tamai, you don't know? No? Very legend doctor. He is not using a torque, but kink the end of the wire and then like this, just rotate and pushing back. And then I try to copy Tamai sensei style, but too late. I cannot change it. And then I give up changing my style, and then I keep doing the right hand control. Small push, never too much push. And then rotate a lot. Maybe you can see my procedure. I rotate the turquoise very much. However, important point of not here. Important point is how move the tip of the wire. So I do rotate the wire and then start the rotate the wire tip, I do counter. And then I control the wire tip direction, mainly inside the 90 degree. So right or upper or something. 90 degree wire movement that makes the blunt dissection toward the center of the vessel. That is my style. So a lot rotate, but not like this one. Like this and this, this and this, this and this. But this is a style. So my style is this one. And I can control. Most important point is control tip wire movement.
Any more questions?
Good?
I think, if no more question, I think, thank you very much, Dr. Sumitsuji. I think he need to have a good rest tonight because tomorrow we'll have
yes, tough cases.
to do 2 tough cases. Again, thank you so much for your excellent lecture to share with us. And I hope we learn something from him. And tomorrow we will have some practical tip and trick also during the live demo. Thank you very much.
Thank you so much.
So this is a 60-year-old gentleman presented with NSTEMI. So we go back to the first procedure in January 2026. So this gentleman with diabetes and ex-smoker with reduced ejection fraction. So this is the angio. You can see that. Actually, this is Dr. Fauzi patient. So you can give a comment also. So this very severe calcification, and we cannot see any collateral to the distal LAD with full of calcification. Yeah. The third also with diffuse lesion with the calcification. So I will proceed to the LCA, and we can see that the LCA also with severe calcification and probably long the body CTO with maybe unclear stump or tract channel with rich collateral, and we can see the antegrade runoff quite well. So then we proceed to PCI at LAD with GL due to short left main with GL T4.5 and 7 French. We use corset, microcatheter, and do a tip injection, and then wire miracle 6. But the microcatheter could not advance to the some kind of band at the mid segment of the LAD. So the operator escalate the wire with Gaia Next 2 and did some balloon modification. And I don't know, maybe this is granuloplasty, probably. Yeah. But still, microcatheter could not advance to the distal, and did an anchor balloon to make a support. Still, the microcatheter could not advance to the distal. So the operator decided to plug modification at the proximal vessel. We did rotational atherectomy at the LAD due to the severe calcification at the proximal LAD with rotabur 1.5. So this is, and do the IVs afterward. So this is the L6, the circ. I think I will move just straight forward. So do predilatation with cutting balloon at the LAD and the circs, and finish with DES at the L circ and the DCB at the PCB, DCB at the LAD. And this is the final angio. Yeah, I think it's quite good. And the patient come again in the June 2026, presenting again with acute NSTEMI with acute decompensated heart failure. We can see the GFR decrease, and we can see the NT-proBNP with a high level, and the ejection fraction reduced. So this is the ECG, and with this all of the therapy at the CVCU. So at the day 4, our heart failure consultant requests to evaluate the coroner. So this is suggestive of ongoing ischemia and worsening heart failure. So I did the angio. So if we look at the left system, the stent quite pattern, and we can see the proximal LAD still good. And now we can see collateral to the LCA, probably rank top 1 and 2. And now, look at the difference. So this, from January, the runoff of the distal from the bridging collateral was good, and now the runoff was decreased. So what should we do? Is there any comment? So I decided to try to PCI to the CTO of the RCA. So with dual access, and due to severe lesion at the proximal RCA, I choose GR with probably get extension support and start with the XTR. And probably we can do a 3D wiring at the mid segment of the RCA. So this is core cell with XTR. Yeah. So after we try to navigate the CTO, but the distal tip was extra plug. So I changed the wire with Gladius and do some projection to navigate the tip of the wire. And again, the distal wire extra plug. And then I back again and change with the Gaia next one and with some projection. And the distal wire is intralumen, I think. So we decided to give more support, and I do predilatation at the proximal lesion and inserted gate extension, but still microcatheter failed to cross the lesion. And I tried to use small balloon crossing, and you can see first balloon was burst, and the second one still also cannot cross the lesion. So this is the final contrast injection. Yeah, I think this is the last result. And lesson learned, I think successful CTO requires success while crossing, lesion preparation, and device delivery. And we should optimize guide support early. Device delivery is often the limiting step in heavily calcified CTO, and recognize when to terminate safely. Thank you.
Okay, thank you, Dr. Dendi. Make applause. Then the second presentation, we would like to present it by Dr. Imade Junior Rina. Artha. Please, your turn. Oh, discussion. Oh, discuss first. Okay, please, yeah. Well, okay, I think we can discuss this case. We open the discussion about 10 minutes.
Yeah, I think Dr. Dendi, the first case, the first procedure is actually chronic coronary syndrome with
ACS with non-STEMI.
with non-STEMI.
Yeah.
And then the second one is
Another non-STEMI.
yeah, another
worsening
so
heart
recurrent or the MACE is actually recurrent
Yeah.
ACS.
Yeah.
And then from the beginning, I think we don't see any imaging or any viability
Yeah.
study. So from the beginning, I think the question is whether the mid to the distal LAD is a viable tissue or not. Of course, the proximal LAD is a culprit because some septal artery needs contribution. But again, what we call risk of ACS is not only to the left side, it's also to the right side. And then it's happened 6 months later, yeah? Okay.
Yeah, I think at the first ACS, from the angio, we cannot see any collateral to the LED, distal LED. So the operator think maybe probably it's not quite a long CTO. So, but from the NGO we can see severe calcification.
If this my patients, then if I saw that no, I mean there's a CTO at the distal LED, and then the CTO maybe functional CTO at the RCA, and then we cannot see any collateral to the LED. Number one in my mind is that is it viable or not, as Dr. Sunanya said, but I have to see the echocardiogram first. I mean, that's if there is a lot of myocardial infarction there, then my first preference is to open up the RCA. That's number one. Number two, if you have already put the wire into the distal RCA, I don't think that we have to stop it. I mean, we have to rota, or we have to, you know, I mean, I do believe that's, even though I cannot see very clearly that any calcification there, but in my mind, it might be calcification at the mid of the RCA, and we have to do rota. That's my opinion.
Yeah, I think since the microcatheters could not advance, and we still a chance of fail for delivery the rota wires.
Yeah. No, I mean that's if wire can go in, I mean that can get through, but the microcatheter cannot get in. That's the Dr. Rifki already mentioned that. Usually, I don't know, Sumitsuji Sensei. I mean, that's for me, is that's put the micro as distal as possible, because you know the wire that you put in is actually 0.014, and the distal part of the wire of the rota wire is actually 0.014 too. So of course, because of calcification, most of the rota wire can go distally without a problem. Maybe around 7%, 8% cannot get through, but I mean that's the majority of the cases. Usually I can put the rota wire, because even though that's microcatheter cannot cross. That's the other problem, as Dr. Surya said, that might be why 6 months then getting ACS. Maybe what we already published is vulnerable plaque. That statin and that the lowering cholesterol should be given to the patients. I mean, this might be, like PCSK9 inhibitor is should be given.
Yeah. I think that the challenge to rota after crossing wire, we cannot because from the previous wire we have extra plaque track. So if we do rota, I don't think that is very safe to do that.
Try. You have to try.
Okay, thank you.
Okay, let's review Dr. Dendi's case. Yeah, I think the first regarding the procedure for the right, what kind of guiding catheter you use?
So we use GR 2.5 7 French.
Yeah, I think that's might be you have to consider to use a more stronger backup. That's the first. So we prevent from the uncrossable device. Yeah. So I think the GR is not so strong. So in that case, if we difficult to use the extra backup guiding catheter, we have to consider what kind of other technique we can use to improve the backup support? Like, do you have like side branch for anchor balloon technique? Yeah. So you have to consider whether there are any side branch that you can easily access and then you can use as anchor balloon technique to improve the guiding catheter. And then the second, of course, like Dr. Munawar has mentioned about using a rota, but the problem is sometimes we lose the access that we have already reached with the other wire. Yeah. So do you use do you have any side branch access to?
I think we don't have any side branch at the proximal. So
no conus branch?
Yeah, no. You cannot see.
Yeah, in that case, I think you have to choose the extra backup, like AL1 maybe or AL2075.
So we did extra backup with the gate extension.
Or gate extension. You already use the gate extension, but still cannot cross.
Still cannot cross.
Have you tried the granuloplasty?
Yeah, no, we use two balloon.
Two balloon for granuloplasty.
Yeah, but we still cannot.
Yeah, I think it must be very tough. Yeah, maybe the last result might be the rota.
Yeah. Where actually the body of the CTO?
Yeah, just after the RP.
So I said this distal part might be still not dissect or something like that, not extra plug. So you have already a cross of the CTO body.
Yeah, I think this is. So from the RV to the acute marginal, I think there's the body, and this is, I think there is no dissection.
Okay, thank you. Your presentation, Dr. Dendi, it's a very interesting case. I think the time is enough, and the next presentation is second presenter from Dr. Imade Junior Rina Artha. Applause. Make applause with Dr. Dendi. Okay. Your time about 20 minutes to presentation and 10 minutes to discussion.
Good morning. Thank you, Dr. Ilham. Good morning, all faculty, senseis also here. Hopefully I can learn a lot from all the faculty here. So I will present my field of CTO cases. These are cases that look like the similar, but of course not the tough case like Dr. Dendi. Let's show this distal chronic total occlusion in the recurring artery. Actually, this is a male gentleman at 52 years old with a risk factor of hypertension, dyslipidemia, and a smoker. And then the patient is with angina with tricuspid disease, refused for kibitz. We already done the stage PCI in the LED and the left circumflex. And then the patient only have a diffuse problem in the right coronary artery. And then we plan for the right coronary artery stenting in the PCI in the right coronary. We can show the ECG from these cases. The sinusoidum with the left ventricle hypertrophy. From the echo is good left ventricle ejection fraction with the left ventricle hypertrophy, and also the mild ER and mild aortic stenosis. So the patient with the ischemic medication and also hypertension medication. From the angiography, we can see the patency of the LED and the left circumflex, and also from the scoring of the GTC score, we can see too, it's been difficult with the Euroscore and the syntax score we mentioned here. Sorry, I cannot get the angiogram from the. We can see from here the coronary artery. We're using a EL1. We can see the diffuse with a good side RV branch. Diffuse from the proximals to the distal part. We can see the tight lesion in the mid part and also the tight lesion, the chronic total occlusion in the distal before the bifurcation. And we can see from the collateral view, we can see the patency of the LED and left circumflex can give the collateral to PL and then and the PDA. So what is the strategy of these cases? I think looks like a long lesion. So in my strategy, of course, we use a support guiding in the right coronary artery, and will be a few escalation of the wire. So and then of course looks like some calcification in the distal part. So from the microcatheter double injection from the we can see there was a blunt stump in the distal part and of the CTO, and then we can see PDA and PL. We can see from the collaterals, and then start with the escalation wire. I choose the first of the intermediate wire with the Pilder XT. Can see they cannot cross the distal part of the CTO. It's quite hard to cross it. So escalation wire with the Gaia 2. So hopefully can cross the distal part. So the problem next is hopefully you can see I got a problem in the proximal of the coronary artery, right coronary artery. There was a dissection, and then we cannot cross the distal of the microcatheter, and then I changed with the run through, but we cannot hopefully, we can cross the run through to the distal part, and we using the small balloon 1.2 Ikasuchi with the, and then they got the granuloplasty and then second balloon using a 1.510 implanted until the burst also cannot cross. So like Dr. Rifki mentioned, using cannot cross the they cannot cross the balloon. So I once again with using anchoring in the rack RV branch with the balloon 2/15. You can see the guiding is cannot even with the EL, the guiding the balloon could not cross also. So in several time I do with the small balloon 1.5. So looks like the very tough classification there. Maybe what should we do after this? I think that's my cases actually. Maybe like Dr. Munawar mentioned, supposed to be we change with the micro with the rota wire, and then supposed to be like that. But because of we're not so sure is it a true lumen or not, and the distal part may be a true false. I'm not so sure about that. Maybe that's my cases today. Maybe any comment from the panelists and also the sensei regarding our discussion. Thank you. The problem is after this procedure, there was a calcification. There was a dissect in the proximal part and also the TIMI flow problem. But hopefully the patient is stable because of the PDA and the PL. There was a gathered donor from the contralateral. Thank you. That's my case today.
Okay. Thank you, Dr. Made. I think we have about the 20 minutes to discussion because the presentation is only the 7 minutes. Maybe Dr. Sunaria would like to comment.
In all cases like this, the most important question for us is we have to consider how large the territory of myocardial ischemia. And that's beyond the angiography, because you perform angioplasty and then you failed, you will not change the myocardial ischemic burden. And the left coronary still help the perfusion to the distal. So this is something that interventionists should consider when we perform a distal right like this. If it's successful, of course, the myocardial ischemic burden will be less. But if not, I think your proximal RCA also injured with the guide, yeah, and then we can see that. So that's why in the future, I think all interventionists should consider some sort like knowledge and skill of non-intervention, like imaging, viability, considering myocardial territory, how large is the ischemic burden. Otherwise, when we success or when we fail, we know the target. That's the dream in the future.
Yeah, I think that's a good insight from Dr. Sunaria. I think we have to also prepare for the worst after we fail of the CTO cases like this one. Thank you. Dr.
Dr. Mangiring would like
Dr.
to
Mangiring, thank you.
Thank you. From both case, I saw there is to the same things. It's how confident we say that this is the Grenada system when we inflate the balloon or we do the ADR, because this is intraplug wiring or we go to the subintimal. So both case, finally the result is, I don't know whether it's in the subintimal flow or in the true lumen. Thank you.
I have to say, is it a true lumen or not? Because we don't have evidence regarding of the IFUS imaging regarding of these cases. But of course, if we saw looks, we cannot predict it clear. Maybe if it's looks like in the intraplug, we're not sure because of huge calcification there or because of other. Is it different in the extra plug? We're not so sure about that. Of course, if I said yes, I'm not confident to say is in the intraplug or not. Maybe we will learn from Dr. Sensei regarding of using of AP protocardium, myocardium later on to make sure is it looks like intraplug or not for the future. Thank you. Yeah. Maybe any comment from other?
Yeah, I think we can. I think you have the second guiding character, right? To visualize the collaterals from the left system.
Left systems.
Yeah, I think we can use that to make sure whether our wire is in the true lumen or false lumen.
This is still part, of course, in the true lumen, but in the
okay.
They mentioned regarding of in the CTO part.
Oh, okay. I think that's no problem actually. Even you are going to the extra lumen and then true, false, true, that also fine in CTO. No problem, yeah. Like usually if we use like reverse card, yeah, that's also usually extra plug. Yeah, extra plug. Yeah, subintimal. So true, false, true. Yeah. That's okay. Yeah. And then I think have you tried what you have used already get extension, right? Yeah.
No, I use I only using a support guiding and also anchoring technique, granuloplasty.
Yeah,
So
yeah.
it's like a
Yes, sometimes the CTO procedure is quite extensive procedure.
Yeah,
We
yeah.
have to prepare everything.
Yeah.
Yeah,
I
and-
already lost 2 balloons, small balloon.
Oh,
So of course
rupture.
yeah, of course.
Oh, okay.
But it cannot cross the small balloon.
You
That's
have tried the granuloplasty
Yes,
as well.
of course, yeah.
Yeah. Yeah, it's very tough. Yeah. Like yesterday, we have seen that how tough is the cases, and Dr. Sumitsuji has tried very hard to solve the problem. Yeah, from the beginning until the end. Yeah. Okay. Thank you very much. Any questions from the audience? Yeah, I think a lot of failed cases in CTO, beside from the failed wiring, also sometimes from the uncrossable balloon or uncrossable device crossing the CTO lesion. But I think several techniques that I have presented, I think maybe we can help us to cross the lesion. Yeah. Okay. Okay. Thank you very much. If no more questions from the panels, thank you, Dr. Junior. Applause.
Thank you.
Yeah.
Okay, thank you, Dr. Rifki. I would like to present the first case of the previous day. We done the CTO case. The first case is
Next.
okay. The first case, Mr. A, 66 years old, with
Pegang
okay,
aja.
thank you, Sensei.
Pegang aja gitu. Ya.
He got engine on award, the history of VPCI of LCX in June 23rd, and the risk factor is hypertension and dyslipid. This is the medication. This is the ECG with depression in V4 and T-wave inverted in inferior lid. Okay, this is the X-ray. And the echo is AF with 50% and hypokinetic at inferoseptal and mid-to-basal segment. This is the CCTA with calcium score 208 unit. This is the coronary angiogram.
Nanti tuh. Setahun lagi.
Okay.
Bonus prosedur kan bisa.
This is the RIO view.
Kelihatan.
Iya.
This is the LCA view. Okay.
Seorang staff mana. Tapi kemudian kelihatan setelah.
This is the post PCI in LCX in 23rd of June. We already done it in the LCX. Okay, so that's the presentation. And next, what is your strategy? Okay.
Could you the volume up? Okay, thank you. So this is the double CTO case, LED total occlusion, and then also like coronary total occlusion. The both of the territory is viable, anterior viable, inferior viable. How should we do? And then he's 60 something, still younger. So the result for this patient, I think that we should open both of the artery. So how to achieve the both success? And then review the angiogram again. Ish. Before that, I always respect the CT. And the CT, most of the doctor checking just only the image, stretch view, stretch MPR. That's made by the technician. And then that is good for we can see the beginning to the end of the coronary artery. And then, there is some stenosis, occlusion, calcified, something. But that is not so good for the PCI support because we lose anatomical the synchronity with the angio. The angio is not like the line. Angio is the 3D, curvature, everything there. So I strongly recommend to use not the stretch MPR, but the SRAB MIP. What is SRAB MIP? SRAB MIP is taking out the kind of the rectangle, the image with some thickness. So using 5 millimeter thickness, this is from this dot line to dot line data coming to here. And then with this image, what we can get is very similar image of the angiogram. This is the areocranial. Looks like the areocranial of the LAD. And then also areocaudal, something like this, areocaudal. Of course, coronary artery have the 3D construction, the architecture. So we cannot see the whole of that. 5 millimeter thickness inside only. However, we can see plaque as well, and the myocardium as well. The kind of information never we can get with the angiogram. So this is a CT advantage. And then how to check the CT? This is my step. First, I got this information, data. Data is like this. This data is this one, 238, the actual data, seeing actual stack from the abdominal diagram and the inferior and then anterior of the heart and then upper side. This stack can make the 3D reconstruction image like this one, like angio-like image. So I never use the technician-made stretch MPR. No need for me. Give me stack. Actual synthesized data give me. That is a 250 to the 400. Sometimes including the Lima, that is 600 something, the data. But each slice is 0.5 the megabyte. So size of this stack is not so big, less than 1 gigabyte. So it's okay. Nothing that worry about the handling of the data. And then after getting this one, okay, put this my application, my own application, or other commercial application also we can do it. And then from here, first I have to check I can check the LV. We are coronary interventionalist, but what the goal of the coronary intervention? That is a good enough flow and then a continuous flow, long-term flow for the myocardium cell. So myocardium is very important. We must check the myocardium first. Like this, making the longitudinal view, and then make the cross-section here. And then we can move from the apex to the basal. And then check the thickness of the myocardium, and also the color of the myocardium, how much damage we can check with a CT. Something here becomes bit thinner. It means maybe damaged. So we have to, here, nice thickness and a nice movement, of course viable. And here, maybe already damaged. Very clear damaged image is this one. This case is like coronary, very much thinner. With a cross section, you can see like this here. Very thin, and also the color become to the black. Color black means already fat something. No myocardium cell there. So this is completely damaged. So not so value for the revascularization for this area. So this kind of information we can get from the CT. So getting the CT and then check with the myocardium first, then, or like coronary, maybe damaged, but still here it's okay. So basal part may be severely damaged, but the mid to apex inferior, it will be okay. So we have the value of the revascularizer like coronary. And the LAD, of course, LAD, that is intact. So we must revascularize. And then must revascularize both. And then how we can do it as the next coming is a coronary. Checking coronary like this. Left main is okay. Oh, LAD occurred. How long it is, we can measure. Measurement is also very important, but just measure from here to something, here to here, something. So that is a 15 millimeter length of the total occlusion. Very accurate, precise than the angiogram, because this is a 3D information. And also, of course, we can see the plaque and the calcium. Not only the longitudinal, this is this cross section of the image checking by this direction. So proximal to distal. That means this image is IVUS. Resolution is much lower than the actual IVUS, but we can get the IVUS-like image before starting the intervention. This is very, very important. And off the center line, and then check. This is the left main, left main. And then circ here. This is circ. Circ here, already stented. And then already ostium here. Some the calcium something, but it's still open here. And then diagonal there. After the diagonal, still some entry maybe here, but occluded. Then calcium here. But this calcium is not completely the mask, the completely occupy the total occlusion, the area, almost half. So we can cross this side. And then here, very low density. So we can make the color map. This is a color assessment based on the CT Hans-Hughes unit. HU unit, Hans-Hughes, you know that? And then red means less than 0, setting. This is my color. So 0 is less than 0 means very fatty. Normal fat is less than 30 or less than 50. But I make the cutoff line of the 0 because this very related to the distal embolization trouble. So this already CTO, but including the very low attention plaque. So after wire cross, when they open up, maybe be careful the distal embolization. Put the filter maybe. And also we check the IVUS. IVUS at lower attenuation was there or not? If the IVUS attenuation, big, massive attenuation, and CT attenuation, this low area, That is a 30% have the symptomatic serious distal embolization. That is my data. So this kind of information we can get from the CT. So nice. And then we already know before starting the intervention. That is very important. IVAS, after wiring, after crossing the wire, after crossing the IVAS catheter, then we can get the information. But not so much time. We have to quickly decide something, the next step. But the CT, we have time. Before my home, and I am checking data. But anyway, so go back. Like coronary. Yesterday, I decided to revasculate, treat the right coronary first. Why? This is based on the collateral situation. This is the previous angiogram, right coronary total occlusion, and there's some entry stamp here. So I think the right coronary can be the antegrade case. Tapered entry and smoothly go in and cross. This is my expectation. And then this is almost a straight cranial view. Also, we can see some entry point here. RA not so clear, but it's okay. And then next point is the left side. Left side, one very nice line here. So that means very nicely we can do the retrograde with this channel. But carefully check. Is this LAD? No, this is diagonal. Diagonal septal. So if we do the LAD CTO first and then successfully open up, we must put a stent from here across the diagonal. Maybe after putting the stent across the diagonal, and then after that doing the retrograde for the right coronary could be difficult. So my strategy, maybe right coronary first as well. And then also for the distal part, not so good collateral coming up because right coronary total occluded. After right coronary open, maybe right coronary PDA collateral grows. So right coronary first. All of the information suggests should do right coronary first. So I choose a right coronary. Okay? Agree? Right. Then go to the right coronary. Then right coronary. This is the right coronary, ne? Number 1. Okay. No, actually, this case already know the very tortuous. Not this case. This case, okay, ne? Okay. And then go to the intervention, this one. Which guiding catheter should be used? In the previous session, the failure reason of the CTO or complex intervention is one in the wires and another one is the device, the deliverability. So backup is very important. Always I use AL1 or short +1 for the right coronary and long tip for the left side. You know,
Side hole.
Side hole. Side hole. If possible, side hole.
Why side hole?
Why not side hole? Why not side hole? Always side hole is better, safer. Just only the advantage of the no side hole is contrast given the efficacy is much better than side hole because side hole, the contrast go away. Only that. And then the total amount of the contrast can be decreased. So renal dysfunction case, think about the no side hole. But we can close the side hole with a guided extension catheter. So I usually use it if we want to do the nice angiogram with using the side hole guiding catheter, I advance the guided extension catheter and then dye injection. Guided extension catheter close the side hole. It's okay. So why not using the side hole? Side hole is much safer. Then one thing, the right coronary and the left coronary is quite different. How to get the backup? Do you know that? That is based on the anatomy. Okay, I take the time to show this feature. Backup, this is very important point. Backup. Actually, maybe, I'm sorry, this is still including the Japanese, but sure. This is very important fundamental of what is the backup. And then please check the CB journal. I published a couple months ago. What is the backup? And the backup formula and how to get the backup for the PCI. So please check it and then the download and check it. Anyway, key word is pushing force and then driving force and friction resistance. This is a very important understanding. We don't have enough time right now, but so I did skip. And then the most important point of the difference between the LCA and then RCA. Yes, this is a RCA. RCA, even using the long tip guiding catheter, but the opposite side of the right coronary is aortic valve or valsalva. So there is a space. No guiding catheter can be fixed without the additional options like extension catheter or the anchor technique. Easily, of course, longer is better, but even the AL2, it's moved like this. And then finally, we lost the pushing force. On the other hand, left, opposite side of the ostium of the left main is the aortic wall. This is very rigid and supportive. So left side, if we can engage long deep guiding catheter, at least EBU 4.0. Yesterday I used a CLS. CS4 is a little bit longer than the EBU, I think. So CS maybe 3.5 or if possible 3.75 is good enough, maybe. But anyway, long one is very effective. And then key point of how to get the backup is not moving the guiding catheter. Guiding catheter move. This is how much move the guiding catheter itself. Much move, low limitation of the backup support. No move, EBU 5.0, that's a very long one. Never move out on the left main, but we can push more and more So 6 French, 7 French, 8 French. Of course, 8 French is better for the backup. Why? That is a rigid, so difficult to move. Even though not a 2-point fix, just only a 1-point fix, that is can move. 6 French EBU 5.0, 8 French JL 3.5. 6 French EBU 5.0 is a much, much higher backup support. So movable guiding cluster is poor guiding cluster. Doesn't matter the size, French size. Doesn't matter the shape. Move is bad. Stay guiding cluster is a good guiding cluster. Okay, and go back to the case. Like Konai, so I already give up getting the nice backup support, just only the guiding cluster. So I always think, of course, it's okay. Some cases okay, just a JR, 6% JR, we can do some easy PCI. Because the resistance of the region is very low. But the CTO, of course, the resistance is higher. We need a backup. So at least the AL1 or SAL1. And then 7 French. Why 7 French? 7 French have the more possibility of the doing the additional options. Anchor balloon, and then final anchor balloon is a power anchor. Maybe you don't know, but the power anchor technique there, that is a huge backup we can get, even for the right coronary. I will show later. That is neither anchor balloon and then wire and then CTO system. So 6 French is possible, but too much resistance inside. So 7 French is much easy. Like coronary 7 French. And then this is a AL1. It's also okay. And then this is a left side. Left side, CS4 cannot engage, so going back to the CS 3.5. And then this is the assessment of the guiding cluster stability for the left side. Right side, I already give up the guiding cluster shape, so I didn't do it. But the left side, that is a very important 2-point fix, aorta and the left main. So I rotate the CM and then try to get the completely, straight looking plane. And then check here and here. Is this inside the left main? Is this touch the aorta? Sometimes looks very good shape, but far away from the aortic wall. At a time, backup is not enough. So check this one, and then dye inject. And then check, not so very clear, but this line is very important. This aortic line, if clear, looks like this is touching. So I think 2 touching. 2-point fix, so I think it's okay. CS 3.5, a little bit smaller is my upgrade point, but it looks okay. And then start, okay? This is even before the starting the CTO PCI. But build up nice system is very important. So I take some minutes to make sure how the system is nice. If the system is not nice looks, I will change the guiding cluster. At this point, guiding cluster change during the PCI, after the wiring, after the ballooning, that is very tough. If you change the guiding cluster, starting point is a good timing. Okay? And then next, this case, I think, this is something the entry point here, this one. So I think this wire, my first wire, Sion black, do the loose tissue, go down, 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 and then here, and then maybe go to the side branch and go, and cross. That is my expectation. However, after advancing the fine Sion black stuck here, and carefully check this point have some angulation here. You can see here and here. And all the wire, I want to go straight down. And then also, CT shows this is not bending. Maybe you remember I one time grab off and then go out from the catheter elbow and go to the control room, and then I control my computer by myself. What I did is checking the root. If the coronary artery bending like this, maybe the wire go inside is good. But this right corner is a very normal curvature. So wire come into the inner side looks very, very wrong. But sometimes good, so I advance the wire, but the wire just only go to more inner side. According to the CT, line of the coronary is like this. Too much inside. Maybe branch, maybe subintima. And then if there's no good collateral channel, I will do the parallel wiring or a little bit advance more down and IVUS to make sure where the wire is. But this case, especially very good channel there. So very quickly, I give up the integrate. I change the wire to the maybe not the Gladius next, XCA. Just only change it to the XCA one time, but go to the same route and then give up the integrate. Go to the retrograde. So maybe some of the doctor more taking the effort for the integrate more, because this is just only this is 8:30 starting wire like this. So 15 minutes, less than 15 minutes effort only for the integrate wiring. This is very short one. And then also including my time to going out and checking the CT. So maybe the feeding the less than 10 minutes. And then I decide, okay, retrograde. Because the channel is very good. And I go to the retrograde. It's okay? Everybody agree to switch to the retrograde? If you have any complaint, please tell me why you don't do the more integrate, why you don't use the Gaia. Never Gaia for me. Well, anyway, retrograde.
Yeah, and I'm thinking that why not you think
Mike, please, Mike.
Why not using double lumen catheter? Once
catheter.
your wire is bending to
yes.
yeah.
That is another option, of course. Yeah. So which is better? Yeah. That is depends on for this patient the channel situation. I think the channel is very smooth, so okay. I straightly switch to the retrograde. If the channel is very tough, I do more double lumen or something.
Okay, thank you.
Already. And then advance this is a Corsair XS catheter, which is good for the microcatheter for the retrograde channel, the negotiation. I think smaller one. So, actually, I'm so sorry for the Asahi-san, but I always using the fine cross. Why fine cross? Fine cross have the little bit more wider the tip diameter, inner diameter. So that means tip injection is much more effective. Image quality is much better than the Corsair. Corsair is very, very good, but a very small in the diameter. So need a medallion, small syringe, and even using the small syringe, sometimes the tip injection image is not so good. That is the number one. Number two, this is number two. Number one is coil. I do many times, I'm so favored to do the channel negotiation. Even looks very bad channel, I try. So many times I injure the channel, especially the non-septal channel. Leave it can make the cardiac tamponade. So coiling is important for me. And Corsair XS cannot getting out the normal cook coil. No, cook coil stacking tip of the Corsair microcaster, because the Corsair microcaster tip is very tapered and the inner diameter is very small. Other tube type microcaster, typically the fine cross, very smoothly cook coil getting out. And then I can manage the leaking. So that is the most important the reason of using the fine cross for me. And then, はい、どうぞ。
Sometimes difficult to negotiate wires going to the collateral because of maybe angulated, maybe the angle is very less than it. So is any possibility that we are using like super cross or so what's your take?
Very bending, no, reverse angle. At the time I do most of the case is LED septal angle, something, right? At the time I do the reverse wire technique, and then get in the septal, and then advance the microcaster, then change the wire. Most of the time I do it. We don't have the tape, what should I say, the kind of the microcaster we don't have in Japan.
And you choose the first, which wire you use first wire for that?
Sion wire. Normally, I do the reverse wire technique with a Sion black. Sion black is a very good, the polymer jacket so nicely slip in, but for the channel, Sion black is for me, the dangerous, the feeling, the wire damage could be happen. So I don't use the Sion black for the channel, almost never use. I know some Chinese doctor, some the American doctor, some European doctor, love to use the Sion black for the septal channel. And then sometimes very smoothly, very quickly cross. So that's okay. I respect their style, but I never follow their style, because I have the experience of the wire perforation. So I don't like use the Sion black for the channel. Probably the channel they passing through with the Sion black, I can negotiate with the Soldier 3 or Sion with more safety. So that is why I don't use the Sion black. And anyway, and then another very important point that Dr. Muna was talking, the curvature angle. For this angle negotiation, which microcaster tip is more flexible, that is Corsair. Corsair is most flexible tip because there are no marker there. All the microcaster have the marker. Marker is metal. So tip is not so very flexible. But the Corsair is no marker on the tip. Very, very. I have the image, but I don't have the time, so I skip. But please remember, if that is very tortuous, very small curve, use a Corsair. Think about the use a Corsair. Then Corsair XS, because we don't have the long fine cross yesterday. And then just a tip injection. I do tip injection. No, this is not a tip injection. This is a little bit more down. This case, before tip injection, wire pass through because very easy. So, but most of the time, advance the microcatheter in the target septal, and then tip inject, and then make target clear or right, left. There's some branch there, right? So go to the left, and then go to the right, and then straight down and turn. The kind of mapping is very important. I skip the mapping this case because I want to do the tip injection a little bit more this part, but this Sion wire automatically go down and cross. So no need to do the tip injection. Yesterday's case, very special. Then next, wire as proximal as possible or as distal as possible, advance wire. Why? Because the wire shaft is more supportive compared to the wire tip. Wire tip is more flexible. So with using a wire tip and then advance the microcatheter, that's making the bending. And making bending increase the friction resistance. So make straight. That is important. That means using the more proximal shaft. So as much as far. Without wire perforation. Too much push can make the wire perforation. But this is Sion wire, and then most of them is 203. Almost very soft and almost no risk of the wire perforation. Anyway, go distal as possible, and then microcatheter. That is the key to success, the cross the microcatheter channel. Then microcatheter go up as much as possible, proximal as possible. Then check the back row. If back row coming, it's okay. Do the tip injection like this. Like this, or almost the touching to the exit of the total occlusion. So, but you can see something here. And if no back row, I don't do the tip injection, and I don't pull back the microcatheter because I already soft wire going up, and then follow the microcatheter. This is inside the plug, inside the lumen. Sion wire, so there's not easy to go to the subintima. So I respect the soft wire following the lumen. So microcatheter is inside, most of the time inside the lumen. And then even not the lumen, but in the plug. Some doctor pull back and then die injection. Why pull back? Again, must go in. So I don't lose this position. If go in, no flow, okay, wire. This is my understanding and style. And then next, retrograde wire, go up and stuck. This is a Sion black wire. Again, my lineup of the CTO wire is a Sion black. And then Gladius. And then Cockes flow, something like that. And then after the stacking the retrograde wire, of course, we have the chance to the advance the antegrade wire. So this is a little bit come to the inner side, but carefully advance again, and then wire come around here. Not to make the wire perforation. Already at this moment, already retrograde system coming up. Okay? Antegrade only. Wire must be inside the plug. I talked to you the first day night. Simple antegrade wire, key to success is the intra-plug tracking. Right? But already retrograde situation. So intra-vessel is okay. Intra-vessel means intra-adventitia. Beyond the media doesn't matter. So this wire never make the perforation, but the subintima is okay. Then, but too much far away. So scary to go back and again redirect. And then like this. Probably this is big knuckle in the subintima space. Or subintima. Here, anterior subintima probably. But at the time, still, I think proximal part is inside the plaque, because a nice entry point there. So plaque and the subintima, that is my understanding. But it's okay, this is the subintima. What next is advanced retrograde wire. But the retrograde wire very difficult to advance. So finally, I changed the mind to advance antegrade the knuckle. Knuckle go down. Why go down? Make the space for the IVUS. So IVUS Boston, the 20 millimeter is needed from the tip of the catheter to the transducer. So we need a 20 millimeter here. So knuckle down, and then finally this one is XTA だったかな? XTA wire getting down. Not somebody. Many doctors don't like this image. Nasty. Violet. But it's okay. Don't care about it. This is inside the vessel. If the knuckle, the outside the vessel, that is a go more straight and go more wider. So this is restricted by the something. That's why this area, this segment. Why not getting bigger? Because there's the adventitia. I love adventitia. Adventitia is very important. Their rubber, not so easy to rupture with the blunt dissection. Punk, sometimes out. But dissect, not so easily rupture. And then this is a nice the length overlap. So do the ballooning, 1.5 ballooning, and then IVUS. Then IVUS coming here. Then what is the IVUS information? The first one is like this. Oh, always subintima. It's okay? Maybe no need my face there. Oh, maximally big the images. No, both is important. So, 2つ出してよ、これ。No need me ね。はい、これいらん。僕はいらない。Yes. That's much better. So this is the subintima. ね? And maybe this is a retrograde wire? Not sure. White dot. Many white dot in the IVUS. So don't believe white dot is a wire. And then important is when the moving the wire, appear, disappear. This is wire. Or continuously. Continuous, decide to the proximal. This is a wire. But just only one white dot. Sometimes not the wire. Anyway, and then IVUS. A little bit more distal. Probably this is from around here. Kuso subintima. Kuso means kind of the fucking something in Japanese. Very bad word. This is kuso subintima. Very big subintima. And this is a calcium. And behind the calcium, we can see this is a wire because continuous. And then disappear here. So this means, this is a bit later phase. This means the wire almost coming to the proximal, so around here. Around here, IVUS is retrograde wire all the way in the plaque. And then coming up, and very close. Maybe already go in だから、next かな。これだ。 So after getting the information of the IVUS, antegrade subintima, retrograde still inside the plaque. Please remember the 2x2 figure. This is a subplaque, subintima plaque. Plaque wire advance. That is a very key important rule. So if the antegrade intima plaque and the sub, retrograde sub, advance antegrade wire. This is a sub plaque. Antegrade sub, retrograde interplaque, retrograde up. Then changing the situation and check with the IVUS again. And then this is after advancing the retrograde wire, here, here, and then come out from the plaque, and then come to the subintima space. So I say that this is all intima plaque tracking, but it's not correct. The small, very short segment is a subintima. But anyway, doesn't matter. And then this wire coming into the anterior guiding cluster. This angle is very accurate, around the 60 degree or 70 degree something. Sometimes this here, there is a space on the top of this curvature. Wire easy to go to space. But in this situation, you can see this tip of the guiding cluster is a little bit getting some smaller, right? That means this part touching to the base wall. No space there. And then this wire, retrograde wire is Gradius, Gradius. Not the Gaia, not the Conquest Pro. Gaia Conquest Pro more easily punk into the plaque here. But intermediate wire, Gradius sometimes go in, but much better than the stiffer wire, puncture wire. So can be bended like the knuckle and then slip into the guiding cluster. So not using the very stiff wire is very important. Oh, why you stand up? Oh, something claim to me. Okay, this is the wire.
Entering. Can you repeat again?
Sorry?
You enter the wire to the guiding. Yeah.
Okay, one more time.
One more time.
Okay, now straight. And then come. And then touch and then bending, small bend here. And then knuckling. Quick. Huh? Yes. I rotate. Not only the push. My style is a pushing, rotate with pushing. So only the right hand, rotate with the pushing. Small, keep pushing force. Always. And then rotate. That is why this is a turn. Tip of the wire turn. Probably many doctors said, why you so many times rotate the torque? I got a many time claim from the Japanese doctor. Why you too much different style? But this is my style. I'm checking the tip. This is not so good. But the tip is like this. Under control. For me, this is under control. And then, next step is a balloon trap. Balloon trap in the guiding cluster. Balloon trap. Balloon trap. retrograde wire up, balloon trap, and then after the trap, microcaster very easily go up to the guiding caster. Okay? Then, next step is trap the, I don't do the rendezvous. I do always the externalization. If you want to do the rendezvous, you can do rendezvous here. But why I like to use the externalization than the rendezvous, there is number one is my style. I did the externalization so many years ago, and from at the time that doing same style. So no time I do the externalization. I try to do it. And then number two, scientifically, externalization have the more backup support because we keep the both end of the wire. So very nice backup we can get. So that is an advantage of the rendezvous. Disadvantage of the rendezvous is need a longer wire. And then sometimes the longer wire friction resistance inside the catheter, that is very much, this case as well. At the time of taking out, very, very tough. Big force is needed. That kind of risk is there. Rendezvous never have the risk. But for me, every time the externalization, so no time I do the externalization. And how to do the externalization, and then trap, and then advance the microcaster, trap again. Trap again, microcaster trap. Not the image, here, microcaster trap, that means not only the microcaster fixation, but stop the bleeding. So after the advanced RG3 wire, and they come out from the integrated Y connector, and the Y connector taken out. Without the ballooning, blood loss is a lot. Ballooning stop the blood. So it's easy. And then the more or less loss of the blood. Okay, that's okay. And then after that is a stand. Final point of the retrograde is a channel check. This case channel is very nice. So almost no risk of the channel rupture, but sometimes using the small channel, we must check the channel before the take out everything. It means I did the, this one.この前か。Pull back the microcaster, あら？ノーイメージだな。ノーイメージだな。Always I do the leaving the wire and pull back the microcasters from the channel. Then guiding caster injection shot from the left side, retrograde side, and then check the leak. If there's a leak there, advance both microcaster, block to and the distal of the leaking point, and then coiling both sides. And then no leak with the retrograde guiding caster shot, just only the tip injection when the taking out, like this. When taking out the microcaster, I do the tip injection and pull back the microcaster, pull back the microcaster. Final check, nothing happened. Hi. That's all. Okay? Final angiogram is like this. Final angiogram. Yes. ね。あ、なんか、not so good ね。一枚足りん？はい。that's good question. This is the style. Now, how you hold the Y connector and then the Turka? Like this or like this? Some of the doctor almost on the table, the Y connector and the Y Turka, like this or like this. My style is like this. I need the distance from the guiding caster end to not the guiding caster end to the Y connector to the my holding is holding はマイクロカッターで取るからでしょ。だから Y connector to the micro cutter end, the distance, the long distance is needed for my style. If that is short, I become like this. Very difficult to do it. I want to do like this. So need this length. That means the longer micro cutter is easy to use. Shorter, like this one, and I don't like to do it. Just only that.
Is any special issue regarding Y connector?
Y connector ね。Y connector、まあ、usual Y connector, Indonesia usually using Y connector, probably.
What's your preference, your Y connector,
okay.
and why? Others, or maybe, every Y connector is same.
No, different.
What's your preference?
いや、だから OKY コネクター。in my room な。ちょっと待って、それより、
先生。
はい。
I have a question.
はい。
Before you advance the IFUS, so you ballooning first the antegrade. Yeah. What is the
I'm sorry, again.
Yeah. For ballooning from the antegrade to for the subintimal space, what is the consideration? This is only short or long for ballooning the subintimal space from the antegrade.
I'm sorry.
Before you advance the guiding, the IFUS, yeah, you do the ballooning the subintimal. What's our consideration to decide this is only short balloon or longer space for the IFUS? For the overlapping wire.
Size 1.5. Not so big one is needed.
Yeah.
And then the segment is a length of the tip of the IFUS cutter to the transducer. The bottom one is a 20 millimeter. So we need a 20 millimeter the far away to the distance. That is needed. That's the point of your point of the question here?
Yeah. Because the picture is there is an overlapping wire antegrade and retrograde. So you just whether you decide or for the only can you show me the
yeah, I will. どこが入るの？これ CD だ。just a moment. CD じゃなくて、アンギオの、どこかな
Yeah,
this
the
one,
picture. Yeah. How long you put the ballooning to make a...
How long means how distal?
Yeah.
Up to around here. But the most important point is plug to subintima connect the migration point. That is a resistance full. And then inside the subintima, actually not so resistance because the subintima is a media adventitious space. So easy to dissect. So not so big the ballooning, the high pressure ballooning is not needed. Sometimes the plug to subintima point that needs a more higher pressure than 12 something. But the later distal part, just only inside the subintima, 6 atmosphere something. That is always I'm doing like that. Okay? And then the distal part is how long is needed. I want to see here, transducer here, IBUS catheter will be here, so I do ballooning up to here. That's it?
Okay.
No, I mean just one confirmation.
Maybe the second case much shorter. Yeah.
No, I mean there's your IVUS catheter is in distal part, okay?
Mm.
And then we didn't see the wire. Why?
Oh, behind the calcium. Sometimes behind the calcium or far away.
Oh, okay.
4 millimeter vessel. I was cut here, so means more than 4 millimeter. So sometimes cannot see. Oh, so next case is more complicated. Eh?
The wire can see no right?
Not always. So,
Okay.
time to finish.
Yeah. I think we have around 25 minutes to review the second case.
Second case ね。はい。じゃあ、quick second case. Quick second case. Second case, I skip the
last part.
very last part ね。that is very difficult ね。Okay. The short lecture, short presentation of the patient.
Okay. Mike, tolong.
Okay, we can go to the second case. This is male, 67 years old with overweight profile patient with increased creatinine function and A1C. Patient with two vessel disease with critical lesion in RCA and CTO in LAD. So we have already done the PCI in RCA 3 days ago. This is the medication, and this is the ECG with QS lead in V1 until V3 and ST depression in 1 IVL and V5 and V6 lead. This is the X-ray. This is the echo with normal EF and regional wall motion abnormality in base apico-inferior segment. Okay, the CCTA showed high calcium score, mostly at LAD. And from LAO and cranial view, there's a critical stenosis. This is the picture before we done the PCI at proximal, and there's a collateral to mid LAD from the conus branch. From cranial view, there's a CTO at LAD. Okay, this is from the caudal and spider view. The CTO is from the ostial LAD. Okay, so we put, this is the post-PCI RCA. We put 3 DES for O and 3.8 millimeter for O and 20 from the ostial to mid, and for O 12 millimeter in distal. This is the final collateral injection after we put PCI. Okay. This is the...
Okay, so quick start.
Okay.
Okay, LAD almost the...
Yeah, so this is actually 2 CTOs, but because I think we have no time for Dr. Sumitsuji to finish 2 CTOs in one session, so we prepare the first, the RCA.
Thank you for
prepare especially for the retrograde approach, because sometimes we need that, so we prepare RCA and that finally Dr. Sumitsuji need it for the retrograde approach. Thank you. Yeah.
And actually, I want to have the more time to growing up the carotid channel. Just 2 days, 3 days is too short. But anyway, this is a angiogram of the left right coronary with a normal. English is not so good, but another important point is not closing the cons branch flow. So that means that this flow go into the LAD very dominantly. So this part we cannot see anything almost. That is why I tried advance the wire and balloon to the cons branch. Then with a balloon here, so no cones branch flow, and then the injection makes a more nicer septal channel visualization. Of course, not perfect, but looks like maybe we can have one here, here, something. So this is the very important tips. Then antegrade. I did antegrade. I skipped antegrade. I did why I was guided antegrade, but failure. Many try, but the failure like this. Just only go to the small septal branch only. And then I'm not sure where the LAD is. So I'm very scary using the stiffer wire. Stiffer wire, easy to make the perforation without a milk mark, without a target sign. So go to the retrograde. Retrograde, that is a 50% lucky, 50% is my skill set. No, 80% lucky. 80% lucky. But one thing not lucky is using the extension catheter very deep. This is a Jadkin slide, JR 3.5. The sitting is not so good, so just only the JR nicely engaged. But the JR backup is very, very, very poor. So I advance the guiding extension catheter and carefully checking the ischemia and then the blood pressure. Some blood pressure down is okay, acceptable. And then finally, I advance the guiding extension catheter here, PDA. So I use a 6-French guided extension catheter, not a 7-French. There's another point. I want to go to deep as possible. Then injection. Injection shows not very clear image, but maybe here, maybe here, maybe here, something. And then I choose the proximal one because this one is the most promising, but too much distal. This one is a connection we can see, but too much distal. So I worry about the length trouble. Then first I try to do this one, and then this decision is honestly very good. Unable to. Just a moment, please. Yoisho. Number 2. Yes, this one, advancing the target septal go this way and up. That is the target route. This one. Advanced course access with a Sion wire, and then Sion wire very easily pass through. Kind of the surfing. It's okay. And then course access also pass through smoothly. That's okay. And then going up to the proximal. But the problem is this part is also very tight stenosis. Actually here, one more subtotal occlusion here, and the big septal, big diagonal position here. But we cannot see even with a retrograde tip injection. And then actually the Sion block can only pass through smoothly, but the Gladius stuck. So I give up a Gladius, and then finally I advance a XTA. This is a big diagonal. retrospectively, the point problem is microcatheter stuck here. So very difficult to change to the stiff wire because this is very tight. Stiff wire easy to migrate the interpark and subintima from this point. That makes the procedure very difficult. So I want to advance the microcatheter more proximal, but failure at the moment. But finally, this is cyan black. Cyan black. Only the cyan black very smoothly go proximal. But the gradient stuck around here. Very dangerous, so I give up the gradient. And the XCA, finally XCA go up, but the XCA also stuck many times. So maybe the black is most working, but black cannot go proximal. And then finally, what the solve this problem of the retrograde microcatheter advancement is the dilate septal. Because this microcatheter friction resistance with the advancement is septal. Even the septal channel crossing is very tough. And then go to here and stuck. Finally, I remember that, and then open up with here septal channel with a Corsair Pro. Corsair Pro is the bigger one. Pre-dilation with Corsair Pro and using the Carabel. Carabel is the smallest size of the microcatheter yesterday, and the Carabel very smoothly go up. So retrospectively, we should do this procedure at this moment. At this moment, cyan black very nicely go down the very big diagonal, very safe. So change to the Corsair Pro, dilate the septal channel, and then advance the microcatheter up to here. That can make the procedure more simpler, more smoother. That is the regret point. But anyway,
sometimes in most of the cath lab in Indonesia, it's not everything's available. If we don't have Corsair Pro, for example, but we have just like that, can we do with open up with the small balloon?
Yes, balloon dilatation. That's a good idea. I will do it without the Corsair Pro. Stuck. ちょっと待ってね。Too much stuck. 時間がない。Time. So 1.0 balloon, if possible.
Size of 1.0.
1.0. That used to be, we use a 1.5, but the 1.5 is a little bit too big, and they make the rupture sometimes.
Yeah, and what the pressure? I mean, there's a low pressure.
More 2 atmosphere, 3 atmosphere.
That's very important for, especially for beginner. I mean, that's I remember in the previous years from now. I mean, that's always with open up
something pink, please pink. The mic, it's coming back. It's coming back. Okay. Number 2, XA. Then, and finally, XCA wire come to the left main. However, that is like the curve. So that means the subintima looks. Left main. And then I do the IVAS to confirm wire in, and then you can see this is the XTA. This is the left main. So far away, not inside the lumen, right? And then IVAS. IVAS also shows it's in the このぐらいかな。You can see here. This is the retrograde wire. No, not これだな。もっときれいにサブインテマ。違うな。これも通ってる。うん。これも。これ入ってるね。なんか違う。No, I'm not sure. I'm sorry. The IVAS is not right now. I cannot find out. But anyway, this is a subintima. So I switch to the antegrade wiring. Now, here is around here, probably here to here. This is a downside of the border of the LED. This is the top side of the border of the LED. So LED target must be here. This is my understanding and the imagination. So I advance the Conquest Pro between this space.
This is retrograde wire.
This is retrograde wire, and then advance the antegrade wire Conquest Pro liner here, this one. Between here. And then of course, not only this view, that change the view and confirm like this. Inside this segment, this zone. Right? Yeah. This is the outer side going around the LED. So LED plug must be inside this curvature. Then also I do the 3D wiring. I don't have the time, so I can't explain so in detail, but this is a counterclockwise, clockwise, and then facing to the center. Then wire advance nicely. And then finally, the Corsair can go in. So I change the wire, step down, because the Conquest easy to go out in the distal part. So change to the Sion black, and the Sion black smoothly, not smoothly, but some advance, some resistance, and then go in. Go in somewhere here. Now go in. Where it is? This is a collateral from the cons branch. Okay? So after getting this one, of course, balloon dilatation and the IVAS to know what happens. And then happening is this, I'm sorry, this is a XA subintima. You can see this is a wire. This is the Artha, left main, and the wire here. Clearly, XCA wire in the subintimal. This one ね。で、まあ、いいや、それはいい。で、and the これか、これ。 this is the situation. Diagonal LED and a septal, and then this is a antegrade Sion black wire in the channel. So this is a true lumen. However, this part is separated by the plaque. So inside the plaque, not a subintima, but not the this true lumen, just beside the true lumen and come into the collateral true lumen. Collateral true lumen. And the collateral true lumen, of course, connected to the septal and the diagonal, right? Because the collateral come into the septal and diagonal. And this wire come into this collateral, but not directly connected to this septal diagonal lumen. Just thinner layer, but go to the different layer. So next step, how to connect these two lumen. My created concave and Sion black, this is go to the collateral, okay? Inside the plaque, already confirmed by the IVAS, not the subintima. And then this is original remain the two lumen, septal and diagonal. The thin layer there. So punk with the concave pro. This is option 1. Option 2 is originally this collateral connected to the septal and diagonal. So reverse wire. Understand? I choose the reverse wire. So this one. I advance the reverse wire to the channel. This is reverse wire, ne? And then this reverse wire tip come to the septal.
Yeah.
And then completely I can get the septal branch. And after that, open up this lumen to the septal. Means that already connect all the way. However, the direction is like this. This one and this one. So this angle is a last problem, last difficult point. But finally, bended Sion wire. This is a trapping and try to advance a retrograde microcatheter. But not only this one, but the corsair pre-dilatation is very, very nice. After the corsair dilatation, caravelle very smoothly go in, already caravelle here. So that is very nice. And then finally, tip bended Sion wire come into the proximal lumen, and then close. Then final image is very nicely revascularized, saving the all of the branch. Like this.
Oh.
Big septal, big diagonal saving. This is the second case, very tough case.
No, I mean that's this is my mind. I don't know. Maybe I'm wrong. But I mean that's when your wire, retrograde wire, XTA going to subintimal. Can we, in my opinion, just replace with the, let's say, Conquest Pro and then small puncturing? Is it what's the dangerous?
One more dangerous is the wire perforation. And then if the microcatheter advance very proximal to the left main LED, left main bifurcation. This is left main. But this is very important, and then the strong rule is sub to plaque, sub to true is very difficult. Plaque to sub is easy. Sub to plaque is not easy. Of course, not impossible. So this is the carina side, and then the advancing the IVUS to the sulc, and then try to navigate retrograde subintima concass pro wire into to lumen of the left main. It is not impossible, but not easy. And then sometimes they make the wire perforation, and that is very difficult to manage it.
Definitely.
Hi.
The IPUS finding is very interesting
Uh,
because at first time I saw the wire goes intraplaque, but there is some sort of spirited. But just I do understand that it is in the collateral channel. So would you please explain some more?
これね。
Yeah.
This situation is もうちょっとわかりやすいないかな。これは。どれがわかりやすいかな。
Jadi IFUS kalau sudah advance ini yang di IFUS bukan vessel ini wire.
Okay, this is a left main, okay? Left main, and then this is LAD.
Yeah.
And then going into the back, okay? And this is a going.
Before that, before this is a sub. This one.
No. This is already in the.
Okay.
違う、これサブインティマだ。
サブインティマ。
サブインティマだ。
Yeah.
Sorry, I did mistake.
Yeah.
違うな。これか。これか。これなんだけど、もうちょっとうまく説明できるやつないかな。これだな。
Masuki.
Something like this one. Okay, I must come to this way.
Pak Sugi tolong IFUS-nya Pak Sugi. Yeah.
So this is here.
Okay.
Okay, inside the channel, big channel. And then pull back. This is another collateral channel.
Yeah.
There's 2 or 3 nice channel from the cons branch. Then here, this is this bifurcation. This part is a lumen I created from the CTO2 collateral channel, okay?
Okay.
And then this is true lumen.
Yeah, the wire still goes on the true lumen, right?
Wire still, which wire? Antegrade wire?
Yeah.
This wire?
Yeah.
This wire is not the true lumen. Intraplaque false lumen. なんかこれ、white ならない。まあいいか。ここが、ちょっと待って。手。どう説明すればいいかな。ここは、こうあって、これ L ね。LAD。で、ワイヤー、インタープラークね。IP。ね。で、ちょうどここが、diagonal, septal.
Okay.
This is septal, big septal here. Septal. And then big diagonal here.
Yeah.
And then this wire is passing through here. This connect to here. And then connect to the
Collateral.
Yes, collateral branch. Conus branch. Collateral. So still something separated. But a little bit more distal, はこうなって、これが、 little bit distal segment is this one. Because already this is a collateral, né? Collateral
Okay. But if very
originally
huge,
connected.
very huge collateral,
Huh?
huge collateral, the size.
Huge.
Yeah.
More than 2 millimeter collateral.
Yeah.
So if this directly connected here,
Yeah.
very easy. This wire, little bit were coming up to this lumen and then proximal. But separated.
Yeah.
Distal part connected, but the proximal separated. So this wire cannot come to here. longitudinal 言ったら、こうなってるってことかな。
Yeah.
こうか。Anyway, let's get wire come to here, but not very easy to go to here. ちょっと説明できんな。うまく説明できてないな。Need a time.
Yeah.
Make sure. But separated. That is more surely separated.
Yeah. If
So-
you the IFUS go to the proximal part, there is separations there.
ちょっとだけプロキシマル言ったら、こうね。This is proximal part.
Yeah.
And then just a bifurcation here.
Yeah. And then some.
And then
Yeah. Go.
go more distal like this. So connection point is just beyond the Pons branch, collateral, diagonal LED connection point, but my wire connect to the collateral just beyond the proximal edge of end of the collateral. So like
Wow.
that is why cannot come.
Okay.
That's
why you
I totally understand that everybody is not so clear because I'm a little bit I'm in my deep mind must be clear but I cannot explain. That means not clear ね。something the problem is this separation. This one is separated.
So what is it? The attenuated plaque, the black. This yeah, that's
This one,
this one.
This one is a plaque, separated original to the lumen and created the lumen. Maybe we need 3 hours.
Okay.
I totally understand.
Yeah, thank you very much, Dr. Sumitsuji, for your excellent review. Yeah, of
Thank you for giving
very
time.
complex procedure. I think we are choose right case for the suitable operator.
Give me the more simple case, please.
Yeah, I think I'll try to simplify or summarize a little bit the learning point from Dr. Sumitsuji. The first, I think, from the case 2, I think there is a smart approach how to improve the septal collaterals. Because it's already 2 days after procedure. Usually it needs several weeks to really develop the septal branch. But in this at this time, Dr. Sumitsuji occlude the conus branch while taking the picture for septal branch. That is, I think, smart way to push the septals open. Yeah, because of the occlusion of the cornospranch.
Come to here.
And then choosing the retrograde septal channels, I think it's very important also. Dr. Sumitsuji using the get extension catheter until the distal, yeah, and then slowly inject. And I think previously also used the micro catheter, so it can reduce the contrast amount. If we use micro channels, micro catheters to put at the like a PDA and then use it to inject contrast, so it's safe using a contrast rather than using a guiding catheter. Yeah. And then we can see here that some operator like do a surfing without real see the collaterals, but I think Dr. Sumitsuji has explained that he doesn't like to use blindly the surfing of the collateral channels. He said that it's safer to use the collateral and then see, we know where to go. Yeah, and I heard that some expert that said that if we inject the micro channels, it will open also, opening the micro channels, right? Using the contrast.
Opening?
Like helping to open the micro channel.
With the pressure?
Yeah. What do you think? Huh? Yes.
Well, some,
I heard some experts say
different story, but some of doctors said micro channel injection make the injure, damage of the channel. Some doctors say.
Okay.
But I don't believe it. That is wrong.
Okay.
Probably that is just only the wire injury confirmed by the contrast injection.
Maybe too strong, yeah?
No.
Oh.
Just only the injection cannot injure the channel. So
but the opening, helping to open?
Opening.
What do you think? Not sure.
Not sure.
Okay.
Right.
Yeah. And this is some micro catheter is more trackable than the others. And I think yesterday we saw that I think Caravelle is very good to tracking the micro channel. Yeah. But the other simple way or cheaper way is to dilate the micro channel. Is it too very tight? What do you think?
For the septal, okay.
Fine. 1.5 is okay, right?
1.5 is a little bit bigger.
1.0,
yeah, if possible.
Yeah, okay. Yeah, so it's still possible to dilate it with a small balloon to the septal channels. And also that in the yesterday case, Dr. Sumitsuji make the connection between the antegrade and retrograde through or within the septal channels, right? In the septal channel.
Second case?
Yes, second case. Septal, and then you block, and then you use the retrograde to that area going to the...
yes.
Right?
The tapping in the...
Yeah, okay. At the septal, right? Yeah, okay. Okay, I think that is some of the learning point that can be learned from the yesterday case, very tough case. And I think we learned a lot from Dr. Sumitsuji from that case. And maybe some additional comment from Dr. Fauzi from the first case. Dr. Munawar, any additional comment?
No comment, except excellence.
Thank you so much. Thank you so much, Doctor.
Yeah, okay. I think we have learned a lot from this 2.5 days workshop from cases and from lectures as well. I think we need to have comments from audience, right? Yeah. Please give a comment from the audience from the right side. Mungkin El, tolong. Siapa yang kasih komentar? Tolong. 1, 2 orang boleh, silahkan. Mungkin Dokter Mangiring kelihatannya mau kasih komentar.
I think it's, I know Sumitsuji say, I think it's since many, many years since, remember that 2011, and I learned a lot from him. For examples like snaring, a homemade snare from you, and then how to do, with the get extension until that. That's at that time I'm still scary about it, but he very nicely to show me how to do that. So I think it's Dr. Sumitsuji is actually give us the concept and logically thinking, rational, and something like that. So I do believe that during his stay here, I think we learned a lot. I do hope, Dr. Sumitsuji, that you can come again and again.
Yeah.
Thank you very much.
Thank you. I'm happy to come again.
Maybe from the left side, Dr. Ika maybe give comment.
Yeah, thank you, Dr. Rifki. I think this is for us, all the attendees. I believe this is a very great opportunity to learn from the great expert like Sumitsuji Sensei, and also all of the our great mentor, Dr. Munawar, Dr. Rifki, Dr. Nahar, Dr. Fauzi, and Dr. Sunaria. Yeah, I think we have a very fruitful event here in Semarang, and also great culinary. Dr. Rifki, thank you so much. Yeah, it's a very great pleasure. Thank you.
Yeah, Dr. Yusuf maybe.
Thank you, Dr. Sadiku Rifki. Well, I just want to say that thank you, Sensei, for visiting us and share your meticulous work. I believe that's one of, on every task that you do, that everything is so perfect. Thank you, Sensei.
Yeah, maybe from ladies from Isyafa.
Isyafa, thank you. We learned so much from 3 days. What I think about CTO, subintimal tracking before this symposium or before this learning, I think that subintimal is harmful, cannot be done, or we must stop. But today we learned so much that intimal tracking is one way to cross the CTO. And I want to learn more about 3D CTO IFUS wiring technique so much. I still confused about peri mio peri VA septal DD sep. Okay, maybe next time we can more from PD. Thank you for the time.
Okay, thank you very much. I think it's the time to close the session. Again, thank you so much for Dr. Sumitsuji to come to Semarang, helping us to create this, I think, quite nice event. Yeah, I hope. And yes, a simulator. Yeah, I think Dr. Sumitsuji has created simulator of planning. Okay. Next time we'll have another section with Dr. Sumitsuji. And on behalf of Indonesian Society of Interventional Cardiology, we would like to give a present to Dr. Sumitsuji. Batik. Batik. Maybe, I hope maybe you have a chance to wear this batik. Handmade batik. Yeah. Thank you. Thank you. Huh? Yes, sure, yes. Short.
Like
Short,
this,
sweet. Yes, something like this. Okay, thank you very much. Okay.
Thank you.
Okay, thank you. Thank you so much. Okay, and again, we would like to thank for everybody also for lecturers, Dr. Munawar, Dr. Sunaria, Dr. Fauzi, Dr. Nahar, Dr. Ilham, and other panelists, and also all the attendees for your time to come here and join with us. And also, thanks a lot for all supporters from Boston Scientific that always helping us to create a great event. And then also from the Fonda, Asahi, and Shimizu, yeah? Shimazu, okay. And also thank you so much for the back office, Santi, El, Mbak Werti, and Pak Sugi, yeah, Pak Sugi, also thank you. And also for all fellows and residents who help us also preparing this event. Thank you again.